sebagai komitmen utama dalam mencurahkan setiap usaha dengan segenap hati kami sebagai komitmen utama keselamatan dan kenyamanan dengan mengedepankan ilmu kedokteran berbasis bukti. Kami terus berupaya mewujudkan Reproductive menjadi smart hospital dengan melakukan berbagai inovasi dan transformasi digital di berbagai bidang pelayanan kesehatan. Rumah Sakit Reproductive senantiasa mengadakan pendidikan dan pelatihan berkelanjutan guna memastikan tenaga kesehatan yang profesional dan kompeten di bidangnya. Kami memiliki 5 dasar nilai dalam memberikan pelayanan yang berpusat pada pelanggan dan mengutamakan budaya keselamatan pasien. Kami
and ongoing learning. Before I start this event, I will show some safety briefing. Committee, please help to show the video of the safety briefing.
Berikut ini adalah briefing keselamatan. Rumah sakit ini dilengkapi dengan kontrol sistem yang berada di security office dan dimonitor selama 24 jam penuh. Sebagai informasi, kami memiliki emergency response team yang siaga 24 jam. Setiap lantai dilengkapi dengan alat pemadam kebakaran, pendeteksi asap, serta sistem pengumuman publik. Dan saat ini kita sedang berada di auditorium. Apabila terjadi keadaan darurat atau terdengar bunyi alarm, kami mohon untuk tetap tenang dan dimohon untuk tidak menggunakan lift. Apabila ada aba-aba melalui pengeras suara, petugas kami akan mengarahkan Anda menuju pintu darurat, menuju assembly point yang berada di pintu masuk atau di pintu keluar rumah sakit. Perlu Anda ketahui bahwa hari ini kami tidak memiliki jadwal latihan keadaan darurat yang berupa bunyi sirine. Apabila hari ini terdengar bunyi sirine, maka itu adalah tanda keadaan darurat yang sebenarnya. Dimohon untuk tetap tenang dan ikuti petunjuk-petunjuk yang telah kami sampaikan.
Mohon perhatiannya untuk petunjuk keselamatan selama berada di ruangan ini. Saat ini kita berada di ruangan auditorium Murni Teguh Memorial Hospital, tepatnya di lantai 8. Ruangan ini terdapat satu pintu masuk di sebelah kanan dan pintu darurat di sebelah kiri. Hal-hal yang perlu diperhatikan saat terjadi kebakaran dan gempa bumi. Jika terjadi kebakaran atau api mulai menyala, jangan panik, tetap tenang. Bagi wanita yang menggunakan sepatu hak tinggi, harap dilepas. Berjalanlah merunduk bila ada asap karena udara di bawah lebih bersih. Segera keluar melalui pintu keluar. Ikuti arah alur evakuasi menuju titik kumpul yang berada di pelataran parkir lantai 1. Prioritaskan wanita hamil dan orang yang memiliki kelemahan fisik. Berjalanlah cepat, jangan berlari. Jika terjadi gempa bumi, lindungi kepala dengan kedua tangan. Carilah tempat berlindung yang aman di bawah meja atau menempel pada dinding. Hindari bangunan yang berkaca. Jika gempa telah selesai dan keadaan telah aman, segera keluar melalui pintu keluar. Ikuti arah alur evakuasi menuju titik kumpul yang berada di pelataran parkir lantai 1. Jangan berlari, berjalanlah cepat agar tidak terjatuh.
Thank you, committee. Next, I will kindly ask everyone to rise for the singing of National Anthem of Indonesia Raya. Thank you, everyone. Can take a seat. Then we will proceed with opening remarks from Head of Pogi Sumut, Dr. Joni Marpaung. He is a consultant of fetal maternal. To Dr. Joni Marpaung, the stage is yours.
Baik, Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera buat kita semua. Mudah-mudahan di pagi ini kita tetap dalam keadaan sehat walafiat. And to our native speaker from Japan, ya. But Dr. Roland Ching and Dr. Sui Lim from Japan. Okay, welcome. From Singapore, not Japan. Oh, welcome to Indonesia, and I think Singapore and Indonesia is very close, yeah. And I think Singapore is the neighbor, okay, from Indonesia, and I think you can enjoy in Medan. Medan is of North Sumatra, okay. Dan selanjutnya yang saya hormati, sini ada abang saya, Dr. Jongkai, dan sebetulnya di sini juga ada sebetulnya guru saya lihat ada Dr. Iwanul, ada Dr. Suti, dan juga ada sahabat saya satu angkatan, ada Dr. Elsa. Kalau Dr. Jongkai ini angkatan 86 ya, Dok, ya. Dan tentu selanjutnya kepada semua hadirin yang saya lihat di sini, kalau yang SPOG pasti saya kenal, ada Dr. Candy, Dr. Heidi Tan, tapi yang lainnya saya mungkin karena bukan dari Objin jadi saya belum begitu, tapi saya yakin bahwa kita adalah keluarga besar Ikatan Dokter Indonesia. Dan tentu nanti mungkin akan bergabung dengan kita juga Ketua PP POGI, ya, Profesor Budi Weko, yang juga mungkin sebagai speaker juga nanti di acara ini. Dan beliau tadi sudah telepon saya, masih di jalan katanya, ya, di jalan menuju ke tempat ini. Bapak Ibu sekalian, tentu POGI Sumut sangat berbahagia, sangat senang dengan kegiatan ini. Kegiatan ini adalah tentu kegiatan yang menambah ilmu kita, transfer of knowledge buat kita semua, khususnya tentu di bidang bayi tabung, ya. Nah, di bidang bayi tabung, mudah-mudahan nanti bayi tabung ini akan semakin berkembang di Kota Medan dan tentu dengan kualitas yang lebih baik lagi. Jadi memang kalau saya tidak tahu bahwa selama ini katanya keberhasilan bayi tabung itu hanya 10-20%, ya. Mudah-mudahan nanti ke depan akan lebih tinggi lagi dengan tentu kualitas anak yang lebih baik. Tentu ke depan kami tentu sangat senang jika ada kegiatan-kegiatan ilmiah seperti ini yang dilakukan oleh baik rumah sakit manapun. Mau Murni Teguh, mungkin ini ada dari rumah sakit Stella juga, ya. Mungkin bisa untuk sama-sama kita mengembangkan ilmu ini, pengetahuan ini, karena saya melihat yang minat untuk bayi tabung ini ternyata bukan hanya yang subspesialis fair, saya lihat yang SPOG yang umum pun saya lihat menyenanginya. Mudah-mudahan karena ini adalah seminat dan boleh dilakukan mungkin oleh SPOG biasa, tapi mungkin di bawah naungan konsultan fertilisasi, ya. Jadi saya tidak berpanjang kata. For our native speaker, thank you very much to your attention. Dan tentu saya mengucapkan selamat, kalau kami di POGI bilang pagi klinik atau siang klinik, tapi ini mungkin pertemuan ilmiah lah, ya. Mudah-mudahan Bapak Ibu sekalian dapat menangkap, dapat menambah ilmu. Dan di atas segalanya mohon maaf jika mungkin ada kata-kata saya yang tidak pada tempatnya. Saya sudahi dengan billahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Thank you to Dr. Joni Marpaung. Next, our President Director of PT Murni Sadar, Dr. Mutiara MHMKT, will give us some welcome speech. To Dr. Mutiara, the stage is yours.
pagi. Salam sejahtera untuk kita semua. Hari ini adalah hari yang berbahagia. Kita bisa berkumpul tidak hanya onsite, tapi juga online. Saya melihat yang mendaftar online juga cukup banyak, sehingga kita mengharapkan acara ini yang bermakna untuk kita semua. Our distinguished guests, Dr. Roland and Dr. Xu, we are welcome you. We are very great today. We have an opportunity that to do this seminar. It will be very helpful and also meaningful for us. Ya, bersama karena hari ini adalah hari ulang tahunnya bayi tabung pertama di tahun 78, yaitu dilahir pada 25 Juli. Ini bertepatan 26 Juli. Ini adalah suatu hari peringatan yang pertama. Di tahun 78 bayi pertama yang melayakan kelahiran Louis Brown yang ada lahir pada itu adalah program bayi tabung yang pertama. Saya rasa ini merupakan sesuatu ya tanggal yang memang bermakna untuk kita. Moga-moga tahun depan kita juga ada acara seperti ini untuk mengingatkan dan mengembangkan. Kita tahu di dunia ini angka ke infertility makin lama makin tinggi. Nggak tahu karena makanan, nggak tahu karena stres. Maybe we ask Dr. Roland and Dr. Xu, why infertility rate is so high now? Tapi terima kasih pada pakar-pakar yang sudah berusaha sehingga kita upayakan bagaimana untuk mengatasinya. Ya, sekarang ini di Indonesia 6 pasangan ada 1 yang infertility. Oleh karena itu Indonesia juga terus berkembang. Di tahun 2024 sekarang Center of Bayi Tabung kita sudah ada 42. Yang tadinya di tahun 90 itu baru 21, berkembang 2 kali lipat. Ini angka yang memang sangat banyak. Banyak penyebab yang dirasakan itu menjadi faktornya. Mungkin karena angka infertility makin tinggi, makanya semua orang berminat untuk mengatasinya. Mulai teguh, memang IVF-nya sudah berjalan lebih kurang 7 tahun. Akan tetapi karena kita lebih fokus pada onkologi, tidak terlalu kami jual. Tapi mulai tahun ini kami akan kembangkan. Tidak hanya di Medan, di Jakarta, juga di semua center-center kita. Klinik infertility kita akan ada di seluruh rumah sakit yang ada di Mulai Teguh. Ya jika perlu bayi tabung bisa bawa ke Medan atau bawa ke Jakarta. Itu merupakan salah satu. Jadi kita juga berusaha memberi pendidikan, insight kepada dokter-dokter umum. Ya, tidak hanya kepada kafer ya, kafer udah gak perlu karena mereka udah cukup qualified. Dokter objin umum yang memang berminat kita kasih education, maybe mereka bisa tangani menjaring pasien kalau butuh IVF baru bawa ke Medan atau ke Jakarta. Itu yang akan kami upayakan. Kami mengharapkan pasangan-pasangan muda yang memerlukan itu bisa teratasi. Dulu saya ingat bayi tabung itu adalah sesuatu yang sangat mahal, susah dijangkau. Sekarang ini harga semakin hari semakin bagus. Jadi sehingga orang medium aja juga udah bisa sanggup spend. Dan juga saya lihat banyak bank yang memberi installment ya. Kalau mau bayi tabung bisa bayar 20 kali, bisa dicicil. Itu merupakan suatu bantuan juga. Kami sangat berbahagia kami melihat berapa pegawai kami yang sudah kawin dan nikah udah lebih kurang 8-9 tahun karena melalui bayi tabung mereka punya momongan. Yang lalu saya baru ketemu staf kami 6 tahun yang lalu, padahal dia nikah udah 10 tahun. 6 tahun yang lalu dia lakukan bayi tabung sehingga anaknya lahir. Dibawa anaknya datang ke kantor. Saya melihat anak-anaknya begitu lucu, langsung bersyukur Mulai Teguh melakukan IVF bisa menolong orang lain sehingga punya momongan. Ya, ini merupakan sesuatu yang penting. Saya mengharapkan mulai acara-acara seperti ini membawa insight yang lebih besar dan lebih banyak kepada semua dokter-dokter bersama-sama kita mengatasi infertility yang ada di Indonesia. Kita nggak usah keluar ke Indonesia aja. We also thank you for both our speaker. We hope that by this opportunity we can learn a lot from you so that we can our infertility cases we can do it more better and increase our rate of success of the IVF. Oke, terima kasih.
Thank you to our President Director. Next, we will play a short video orientation about the Pelataran Sehat program for our Indonesian Doctors Committee. Please help.
Halo Bapak Ibu peserta kegiatan, sebelum memulai kegiatan kita, kami dari Murni Teguh Learning Center akan memberikan pengarahan penggunaan pelataran sehat. Berikut link untuk nakes. Berikut link untuk non-nakes. Pertama, silahkan login atau masukkan akun Anda melalui Satu Sehat untuk nakes dan Pelataran Sehat untuk non-nakes. Kedua, masukkan email dan password Anda yang sudah terdaftar. Ketiga, masukkan kode CAPTCHA yang ada di sebelah kanan kolom. Keempat, pilih masuk. Jika email, password, dan kode CAPTCHA Anda benar, maka Anda akan berhasil langsung masuk ke akun Satu Sehat Anda. Jika email atau password Anda salah, silakan mengingat dan mencoba kembali terlebih dahulu. Silakan hubungi pihak panitia. Setelah Anda berhasil masuk, di sebelah sisi kiri, pilih Pelataran Sehat, lalu klik Cari Pembelajaran. Namun, jika yang tertulis tautkan akun, silahkan menghubungi pihak panitia. Pastikan tampilan Pelataran Sehat Anda menampilkan nama Anda dengan jelas. Jika tampilan tidak seperti berikut, mohon kembali ke halaman sebelumnya, lalu klik Cari Pembelajaran, sampai menampilkan nama Anda dengan jelas. Kemudian, klik nama Anda di sebelah kanan, lalu pilih pembelajaran saya. Selanjutnya, klik belum dimulai, lalu pilih judul kegiatan yang Anda ikuti, pilih detail webinar atau seminar, lalu pilih mulai belajar. Jika muncul notifikasi berikut, mohon menghubungi pihak panitia. Silakan menyelesaikan pembelajaran sampai dengan evaluasi dan pengisian rating untuk mendapatkan SKP Anda. Sekian pengarahan dari kami. Selamat mengikuti kegiatan. Terima kasih.
Thank you, committee. Next, we will start our program. So before we start, I would like to introduce our new moderator because Dr. Irwansyah has a scheduling conflict. So this session will be moderated by Dr. Hedi Tan, also OBGYN. To Dr. Hedi Tan, the stage is yours.
Ya, oke. Ya, terima kasih. Kebetulan kita di bidang objin ya, jadi hari ini kebetulan Dr. Irwansyah nggak bisa memoderatorkan, dimintakan saya untuk moderator mendadak ya. Oke, terima kasih. Welcome to Indonesia, Dr. Ronald and Dr. Sri. Yeah, as our POGI, just now the head of the POGI in Sumatera Utara, say this Singapore and Medan is a neighborhood. Okay, so welcome to Medan. Okay, sebelum memulai seminar ini, saya akan membacakan beberapa pemateri, mulai dari, ya, jadi seminar ini adalah blending learning ya, seminar medis internasional mengenai advance in reproductive medicine, bridging modern medicine from the diagnosis to treatment of infertility. Pembicara pertama udah? Prof. Budi belum datang ya? Oke, karena pembicara pertama belum datang, kita skip dulu ke pembicara kedua ya. Jadi saya perkenalkan pertama Dr. Roland Siu Kai Heng, ya, born in 20 September 1968, and is a doctor and medical director. Work at the Roland Chiang Family and Women Care in Singapore. And then she has a degree of MBBS and MRCOG, and so on, so on. Okay, so we welcome Dr. Roland. Please take a place. Okay, oh, doctor, sorry. Okay, sorry, I try to refer. Okay, the first speaker is the Dr. Liu Siu Lian. He's a Malaysian, born in Malaysia, is it, doctor? Okay, and is a scientific director for Fetus Fertility Center in Singapore, and she has a PhD degree. Work as a IVF more than 30 years. Okay, today the title is How to Improve Pregnancy Outcome in IVF. So, please, doctor, take your place. Thank you.
Good morning, ladies and gentlemen. Thank you very much for Hospital Murni Teguh to invite me to come to share the knowledge and experience with you all. Also, just to let you know, as Dr. Mutiara just mentioned in her speech, yesterday we celebrated World IVF Day and also the World Embryologist Day. So it's a very good occasion for us to share our IVF experience and also the hope. And to me, it's a two-way traffic. Yeah. So after this we can discuss, we exchange ideas. Yeah. Can I have the slide control? Yeah. So my talk today is on how to improve pregnancy outcome in IVF and what are the factors. First slide, please. You don't have a slide control? Oh. So what factors that influence the outcome of IVF? So basically what happens there, of course, you talk about the sperm, you talk about the oocytes or the eggs, and of course, very important, the IVF laboratory. So now the next slide, please. So now, just this slide, just to highlight to you just to let you know, when a woman is conceived, she has been given so-called about 1 to 2 million eggs, both stored in the ovaries. And over time, by the time she reached puberty, she probably has lost half the number of eggs in her body. Next slide, please. Now, just basic knowledge now. fertilization, very simple. What happens is that the fusion of the egg between the egg and the sperm. So what happens is that what you see in the diagram here, I'm sorry, I don't have the pointer also, that the sperm will go to the A side, then they go through the egg through the cumulus cells, pass through that, and then the sperm has an enzyme called acrosine that helps to digest the eggshell, drill the tunnel through, and after that fuse with the egg and fertilize the egg. So once it's fertilized, and then it develops into an embryo, and what you see on the left side is a human egg. It's magnified 5,000 times, and it looks like a tennis ball, and in the middle you see the sperm is attached to the eggshell before going in, and the right side here, on the left side here is the blastocyst, which is the final embryo's development stage, pre-implantation stage, before it implants into the womb and give rise to a pregnancy. So the aim of the IVF treatment is to grow the embryo up to the blastocyst stage, and so that effectively you know there's a higher chance of giving a pregnancy. Next slide, please. So what do we have to do to make IVF successful? Of course, first of all, we have to select a healthy sperm. Next slide. Now, all of us are very familiar with this semen analysis. Now, this is based on WHO 2021 parameters now, recently. Now, it has revised to sperm concentration. So, any man that has a minimum sperm count should be 16 million, all right? And motility, you look at, should be 30%. Vitality means that how many percentage of the sperm is alive, because when the man ejaculates, not every sperm would be alive, so it should be at least 54%. If it's less than 54%, then the doctor will have to find out what could have caused more sperm to die. Yeah? Morphology, the shape, how many of the sperm has a normal shape, or so-called Olympic swimmers, yeah, very handsome swim, because the sperm has to have very fit and develop very nicely so they can swim all the way to fertilize the egg. Now, this is just to highlight to you that this is 2021. When I first started my postgrad in 1990, yeah, the WHO parameters was the sperm count. Let's go back to the same slide. The sperm count was 20 million. All right, but now it's 16 million. All right, and morphology was next. Not this slide. Go back to the previous slide, please. Go to the semen analysis, please. Yeah, thank you. Pointer, okay. Okay, thank you. All right, so now over here, the morphology part. In the year 2000, the WHO, the morphology to determine whether the man's sperm can fertilize an egg is 15%. But now, you look at it in 2021, they have to revise the sperm, lower down the standard. Now, if you were to use that standard in the year 2000, all of our men now will have problem fertilizing the egg or become very subfertile. Yeah? So now you have to have 4%. This is what they're telling you now, because now the sperm quality has dropped, yeah, in all men now. Okay. Now, you look at this picture here. This is the sperm. It makes up of the sperm head that contains the DNA. The neck is the powerhouse, and of course the tail is there to help the sperm to swim. Now, you see some sperm, for those in the lab, you can see some sperm with poor motility or some good motility. That is because of this, what we call a cat sperm protein, right? So this is just to tell you that if there's a defect in this protein here, the sperm motility will be affected and the healthy sperm will be swimming very vigorously. Okay, so this is just to show you the function of this Casper steam. I'm going to jump. Next slide, please. Now, in natural fertilization, what happens is that the sperm, the Casper positive protein, will go through the cumulus cells and then attach to the zona and then go and fertilize. But those sperm that have poor motility will be unable to fertilize the egg. Yeah? This is the latest development research work. Next slide, please. Now, normally in IVF, the fertilization rate that is acceptable is 80%. Yeah? And the pregnancy rate, if you base on the cleavage stage embryo transfer, could range between 35 and 45%. Cleavage stage transfer means you transfer one day 2 or day 3 embryo, and the blastocyst stage transfer is 55 to 60% pregnancy outcome. Now, of course, in some men, we have what we call a global spermia, whereby the sperm has no acrosome at all. Right? Acrosome means there's a cap that helps the sperm to drill a tunnel through the eggshell, and because there's no acrosome around, so it's unable to go in and fertilize the egg. So you need fertility treatment, or ICSI, and of course, cardiogenic syndrome, meaning that most of the sperm are unable to swim, yeah, but they're still alive. And of course, this one needs ICSI. Basically, what happens, next slide, please. Now, what happens here is that in normal fertilization, what happens is that the sperm comes in, go through a tunnel, and the sperm carries an important protein that activates the egg, meaning that you just imagine that this is, the egg is a sleeping beauty, right? And if the sperm, then when the sperm gets in, it kisses the beauty and says, "Hi, darling, let's get the work going," all right? So, but most of the sperm will have no protein at all, or this activating protein, or very little, and they can't activate the egg, and fertilization will not happen. Now, this is just to show you the activation, because this is called, activation means that when the sperm gets into the egg, there's influx of calcium. Calcium is very important for all physiological processes, including fertilization, and it causes all calcium spikes, and from this, it will initiate fertilization and embryo development. But for some sperm, the spikes are not there, all right? So sometimes you have seen men, for the embryologist, so if you look at sperm with no cap or no acrosome or small acrosome, that could be the issue here, and ICSI has to be done. Now, and also, sometimes in the semen analysis, the sperm morphology looks okay, the acrosome is good and everything, but there's a defect in the mutation of this enzyme, okay? So once it's this defect here, the fertilization rate will be affected. So sometimes what happens is that this one, this is more for research work, more for academic, but for treatment, it's very easy. Yeah, I can share with you later. Now, total fertilization failure, for those who are working in the lab, you know, what causes the total fertilization failure? It could be because of the failure of mature oocytes to fertilize in AIT cycle, or affecting 1 to 3% of the ICSI cycles. So some of these are because of the sperm factors. The other one could be because of the egg factors. Yeah. So I'm not going to talk too much of this because I'm given a limited time, but we can discuss later on after the talk. Now, in addition to that, the sperm, everything, a lot of sperm involved, yeah? So the sperm also, let's say the head is okay, but the centrioles, the neck part, contains what we call is important for fertilization. Yeah, in human, the neck is important. The sperm neck is important for fertilization, but in the mouse, there's no issue. You can inject the sperm head inside. You still get baby pups from mice from there, but in human you can't. Yeah, because this is important for a chromosome segregation, separation during cell division. Now, if you look at it this way, so the sperm is made, the head, the milk piece is made up of this 9 sets plus the middle, and this is the defective ones, yeah? The defective ones could be this is the normal, the defective one could be this. So it affects the motility and probably aneuploidy in the embryo. Now this is just to show you the two chromosomal between infantile sperm and fertile sperm. Now, this is the latest development that we highlight, I stress a lot on this, is the sperm DNA quality. Now, in the olden days, we just look at the sperm count, motility, and morphology that affect IVF. Now, currently now, what we are stressed on, that in addition for semen analysis, we have to look into the sperm DNA quality in terms of how many % of the sperm can be damaged. Now, in school, we have been taught that the job of the sperm is just to fertilize the egg. But actually, the sperm has a major impact on the outcome of pregnancy as far as the first 3 months of pregnancy because of the sperm DNA. So if there's an increase in the sperm DNA damage, then there's a higher risk of pregnancy loss in the first 3 months of pregnancy, gestation. So what happens is that these are some of the factors. What could be, I think Dr. Roland can share with you later on, what could be the factors that cause sperm DNA damage, and some of the factors can be cigarette smoking, too much alcohol, pollution in the environment, radiation, and so on and so forth. Now, so this is the impact. So the sperm can have impact on the sperm quality. So in the lab, the embryologist will look at the eggs and then or the embryos, a lot of fragmentation, or even if you have a blastocyst for transfer, there's spontaneous abortions. So this is just a highlight to you, the EM microscope of 4 sperm head. So what happens is that these are the 4 sperm, and the dark material is the chromatin or the DNA of the sperm. So those with the crosses means that the sperm had been badly damaged, the DNA. All right, and you see all these vacuoles here. Now, all these vacuoles, if you look at high magnification, they look like holes on the head. Yeah, so that's how and this is one of the tests for sperm DNA damage. We call it the hallosperm test, whereby the sperm sample is treated with chemicals to break down the cell membrane so that the sperm DNA is spread out. So those with the large halo, we call it the halo, that tells you that this sperm had good DNA. So those small halo or no halo at all tells you that there's DNA damage is very high. Yeah? And then the lab will look at about 300 to 500 of this sperm, generate a percentage, and the lower the percentage, the better it is. All right? So, but no man can reach 1% or 0%, no matter where he lives. Yeah? If you have good life, paradise, good air, good food, there still be at least 1% damage. All right? Now, so what can we do? So, of course, now the common method is ICSI, intracytoplasmic sperm injection. How can I activate the video? So the sperm, can you please activate the video? So the sperm is selected and injected into the egg. Now the first ICSI baby born was 1992. That is in the world by Belgium, in Belgium. But was in Singapore, yeah, in 1994. So I was involved in this procedure here. Yeah. So now, most of the conventional way, we are dealing with ICSI. Now, I'm going to share with you what we do now is that the latest one, the modification is IMSI, whereby you spend more time selecting a healthy sperm to get in. That is because, as I said, the sperm has a major impact on the outcome of pregnancy. Now, how are we going to do that? Now, by looking at this test now, as I showed to you, this is the maximum magnification for ICSI, so you may not see much detail of the sperm. So what happens is that if you magnify to 1,200 times, you see more details of the sperm. As I mentioned, the head contains the DNA. If you see holes on the head, that means that this sperm had badly damaged DNA, then you're going to use it. Even if it's a single hole, you don't use it, all right? And let's say this sperm had no holes at all, because it assumes that it has good DNA, but the neck is not smooth, so it's not handsome enough for the egg, so we will reject it. Now, why we spend so much time on this, selecting the sperm? That is because the egg is a marvelous entity, all right? So when the sperm gets into the egg, first thing the egg will do is to do housekeeping work, meaning the egg will use its limited resources to repair the sperm DNA before it becomes an embryo. So if the damage is very minimal, let's say 3% or 5%, that's okay. The egg can use its limited resources to repair the DNA, give rise to a healthy embryo and healthy outcome. But if the DNA damage is more than 10%, then the egg would need to spend more time, more of resources to repair the DNA of the sperm. But most of the time, it cannot repair 100%, and it may just stop growing on day 2, day 3, or it reaches the blastocyst stage, and because of the damaged genes present in the embryo, if it implants, this woman has a high chance of pregnancy lost. Now, contributing factors to sperm quality, environmental and lifestyle. I think afterwards, Dr. Roland is going to stress on that. Now, what's the impact? So this is the impact here, yeah? What's the paternal? The fathers also contributes, yeah, to all these things, the sperm, yeah? Now, let's look at the egg now. After selecting the sperm, of course, we look at the egg, yeah? Now, what are we talking now? Oocyte number or oocyte quality? Now, unfortunately, unfortunately, most of the medical journals, they talk about number of eggs. They are very happy to say, oh, the more eggs you get, the better it is. Yes, statistically speaking, yes, you can have more eggs being used and more, at least you have got 1 or 2 eggs that are good. But to us here, to the lab, oocyte quality is more important. As long as you have 1 good quality egg, you are sure to get a good outcome. So 15 oocytes, based on statistical analysis, they say that 15 oocytes is to generate a live birth. Poor responders and women with low AMH will have fewer eggs retrieved. So in other words, if you follow this 15 oocytes, those older women or those women who have low AMH will have to go for a lot of cycles before reaching there to try to get a live birth. All right? So this is very financially and emotionally traumatic to the patient. So you may require a few egg retrievals to get a live birth. And so can oocyte quality, rather than the number of oocytes retrieved, be the key factor to optimize live birth rate? So now the emphasis is to go to quality rather than the number. Now, this is how the human oocyte looks like. It comes with the cumulus cells, meaning the egg is here, and there are a lot of cells around. Now, these cumulus cells are the nurturing cells. They provide the egg nutrients for egg to grow when it's in the follicle and to make sure the egg is mature, ready to be fertilized by the sperm when it's ovulated or retrieved, yeah? And also helps in sperm selection in natural IVF. Excuse me. Natural fertilization. Now, if you remove all these cells, what you see is that this is the eggshell, zona pellucida. This is the egg proper, where all the resources for fertilization, embryo development is here. And this one tells me that this is a mature egg. Mature egg means this egg is ready to be fertilized. Now, this type of egg is good, but not all the mature eggs are like that in terms of quality. Yeah? So what is oocyte quality? Oocyte quality is defined as the ability of the oocyte to achieve meiotic and cytoplasmic maturation, fertilize, cleave, form a blastocyst, implant, and develop into an embryo to term. So now, oocyte with the best development potential is determined by how mature the egg is, then the morphology, the shape, and how competent it is. Competence here, even though it is mature, metapase 2, but the resources are not enough, then the embryo may not be able, the outcome of the embryo will not be good. Yeah. So now, sorry, this is a bit more scientific. So first of all, there are two types of maturation. The first maturation is the nuclear maturation, then followed by cytoplasmic maturation. Now, what do I mean by nuclear maturation? Now, as you know, that the egg is stored in the ovary at a very, very immature stage. So over time, it takes to grow from a germinal vesicle to a metaphase 1 to metaphase 2 before being ovulated. So this maturation here, it takes time, and that's why in stimulation program, the doctor have to give the patient FSH for at least 10 days to at least get the more mature eggs from her. Next slide, please. Now, this is just to show you the scientific way of telling you this is very important. Mature eggs where the chromosomes are aligned in the metaphase there, which is the correct one. These are the defective ones, and this is a defective ones too. So they give rise to embryos that are genetically not healthy. Now, this is the normal way to show you that in metaphase 2, separation of the chromosomes, and then metaphase 2, and this one will give rise to a healthy embryo with the even chromosome number. But as this one, the defect of the meiotic spindle. Next slide, please. There's some defects during the development, and then there's some chromosome left behind, or this segregate, and all those things. This one will give rise to embryo that are aneuploid. Next slide. Okay. So how are we going to determine this? This is a new technology. So most of the time, the lab will look at the egg. Oh, this egg looks good. Yeah. But they don't know how healthy this structure is, as I mentioned earlier. So what happens is that we use this technology known as polarized light microscopy, whereby if you look at this egg looks healthy. You have to look at how healthy the meiotic spindle is. It gives you a bright spot, and this bright spot has similar shape, and this egg has at least 80% chance of giving you a good outcome, low risk of pregnancy loss. But in this egg here, this egg, it looks healthy, but this structure here is stuck between the small cell and the egg. So this one will give rise to abnormal embryo, genetically not healthy. Embryo loss is very high. And this one here, this egg looks healthy, but internally, this structure has been broken down. So, and then it gives rise to a high risk of embryology loss, pregnancy loss. So this one usually happens in women who have a history of recurrent miscarriages or failed implantation, and in older women, women in their 40s, yeah? Next slide, please. And control. So this is just to show you again how a healthy one looks like, examples of unhealthy ones. Now, another thing is that for the lab, now, as I shared with the embryologists in this IVF center here, I was asking them how, after egg collection, or how long is the incubation before you remove the cumulus cells. So the cumulus cells actually has very deep penetration to supply the nutrients into the egg. So this is very important. The timing of removing the cumulus cells is very important. The longer you incubate, the better it is, yeah? And this is to tell you the cytoplasmic maturation, meaning that in the very immature stage, the resources are not ready yet, and here all the mitochondria are okay. All right? So the morphology, all these are the things that you can see here. Sorry, the images are very small. So poor fertilization outcome, it can result in abnormal fertilization, fail to fertilize, or poor embryo quality, or sometimes this embryo has failed to implant and miscarriages can happen. So the competence, it could be because of maternal aging, yeah, and also stimulation protocol. The LH effect can improve the oocyte quality. So in older women, why in older women in advanced age, like 40s and above, how come they can produce good embryos but higher miscarriage rate? It's because of the mitochondria. The mitochondria is also aging. Mitochondria, as you know, is the organelle that gives energy to all organisms. So if there's lesser energy for separation of the chromosomes, it results in abnormal chromosome distribution. So aneuploidy rate is high, so it's a high chance of a miscarriage or embryo cannot reach the blastocyst stage. So just to show you aging. And this is just the influence of age and oocyte quality. If you look at this study here, those 35 years and below, you see the mitochondria viability is so good, and those at 35 and above, mitochondria viability is less. All right? That's one of the reasons why in older women, she has difficulty having a live birth. So this is just to tell you the aneuploidy rate. As a woman gets older, aneuploidy rate goes up, and number of youthful embryos goes down. Yeah? So in conclusions, optimal maturation of oocyte depends on its environment and determines embryo competence, mitochondrial function, and energy production deteriorate with age, adversely affecting ovarian reserve, chromosome segregation, that means give rise to abnormal chromosome number, embryo competence. So mitochondrial metabolic stress can result in abnormal compensatory increase in mitochondrial DNA. Yeah? So the addition of LH activity to FSH, in other words, combine FSH plus LH in the IVF stimulation protocol will benefit older patients through a higher synthesis of androgens, which are diminished in older women and may enhance oocyte quality and embryo quality. So enhancing oocyte competence is a key intervention that promises to reduce the number of euploid embryos failing to produce viable deliveries. So now the next one, the last one, we'll talk about growing the embryo. After fertilization, how we grow the embryo. So video, please. So on the left side is the video of a time-lapse embryo growing from fertilization to blastocyst. Yeah? So the embryo grows from day 1 to day 5 or even day 6. So each cycle is 24 hours. So if there's an this one can, and during the development of from day 1 to day 5 or day 6, the embryo does self-correction. So during that time, if the embryo reaches the blastocyst earlier than 120 hours, we can say that the embryo is healthy, has a high chance of implantation during a live birth. But those embryos that takes longer than 144 hours, that means that there's actually there's some issues along the way. So the embryo quality may be affected, genetically will affected, so high chance of pregnancy loss. Yeah. So this is just a picture to show you how a time-lapse incubator is. So the advantage of time-lapse incubator is that you don't need to take out the embryo to check every day, or because each time you take the embryo out, you expose them to more stress in an unnatural environment for them. But in the time-lapse, it's a closed system whereby there's a camera recording the development of the embryo for 5 to 6 days, and then you can play back here and also help the embryologist to select the best embryo for transfer. Now the latest one also has included the AI inside. AI means artificial intelligence. Now artificial intelligence will not replace the work of embryologists, okay? It's just as a tool to help the embryologists to select the best embryo for transfer. So this is how the diagram shows you the implantation process. And the factors that impact implantation, of course, is the endometrial receptivity, how receptive the environment is for the embryo, and also depends on the embryos, whether they have euploid or aneuploid, of course, it will affect implant outcome and the ability of the embryo to hatch out and implant, all right? And this is just to show you our lab. It's a clean air facility, all right? So air quality is very, very important here. So the minimum air quality is ISO 7 or Class C, but when we come for getting an external audit to audit the air quality here, we have reached ISO 5, which is the higher quality. So air quality is very important. And also the temperature here is 25 degrees, cannot be too hot, can be too low. And the eggs and embryos are handled in this style of crib here, where the optimal conditions are maintained to reduce stress. And what you can see here, fertilization is here, and then embryo transfer is done in another room. Yeah. And this is just to show you the embryology preparation of sperm for IUI, IVF, the benchtop incubator for incubating the eggs before ICSI or IMSI, and then the storage of the embryos in liquid nitrogen tank. And relative contributions of oocyte, sperm, and uterus to successful live birth. Unfortunately, the egg still contributes 70% of the successful outcome, the sperm 20%, and the uterus 10%. So inverters, what happens is that we have this holistic approach whereby all the different pillars, like the doctors, the nurses, the embryologists, yeah, and the fertility coach or emotional counseling, and the admin staff all play as a team to try to help the IVF couple to achieve a good outcome. I thank you.
Thank you, Dr. Shu. Dr. Shu, please have a seat here.
Okay.
Jadi pembicara kedua, Prof, maaf Prof, pembicara dua Dr. Roland dulu Prof ya, nggak apa-apa. Oke, so pembicara kedua Dr. Roland, please Dr. Roland have a seat here, take a place. Dr. Roland have a medical director in Roland Chan Fertility and Women Care in Singapore, and have a degree in MBBS and MRCOG. As well as a fellowship in the male infertility, reproductive, microsurgery, and assisted reproductive technology. And now is a practice in the private specialist consultant in Parkway East. Please, Dr. Roland.
Thank you. Good morning, everybody, ladies and gentlemen, fellow colleagues. It is indeed an honor to be here, to have the opportunity to share what we know about IVF and also to learn from each other. So I'm looking forward to further collaborations in the future. Now, I'm sure our audience today, they are all our OB/GYN colleagues. I am a trained OB/GYN, but my last baby that I delivered was back in 2017. So now my work is mainly into IVF and fertility. So now looking back for the last many years, 2 to 3 decades now, I think the last time I was here in Medan was 15 years ago. And I remember that was also, I'm talking about the same topic, not the same topic, but very much into IVF. And I must say that looking back at the slides that I had, I'm not sure how I still have the slides. It was a bit emotional because things have changed so much. And I think whatever slides that I talked about 15 years ago will not be applicable today. So things have changed so much, and similarly, I think what I've seen in Medan also has changed so much. So it is really emotional for me to be here again. I'm very happy to be back. Today I'm talking about male infertility and of course the contribution of sperm. We heard a lot about sperms earlier. That will be the laboratory part. But what I want to emphasize on is how the laboratory could become applicable in clinical setting. I think being a clinician, I think this is always close to our heart. We want to have the idea how all this new knowledge will be able to translate into clinical practice. So now to my view, my opinion is that I think the contribution of sperm in this infertility treatment is huge. And I would say that I'm in a good position to tell you that your investment in clinical assessment of the male factor infertility would be rewarding because we have seen high success from our IVF cycles. So let's dive in and look at what the current development in male infertility. Am I able to control my own slides? Does it work? Okay. Pointer is this one. Yeah. Okay. Okay, so this is the outline of my session today. We're going to focus on what are the factors that affect sperm function and the man's fertility, and what are the general health and that will be affecting the reproductive health. What should we do? How we should approach male infertility, and what are the other investigations into male infertility? And then after that, I'm going to emphasize a little bit on the current applications of semen analysis and how we should be looking at it. And of course, I'm going to stress a lot of importance on sperm DNA damage assessment and the impact. Now, men, very different. So these are the things that I've always been stressing on whenever I talk about male infertility. I think the first point we all agree among the men among us, we are always reluctant to see a doctor. We only see a doctor when the issue is pressing. Someone say that if you don't do it, something's going to happen to you, something like that. Then you will get to see a doctor. And we want repair. We are not interested in prevention. We want repair. We want a solution. And the repair cannot be just a repair. It has to be quick. And we want to leave the doctor's office with a solution, with a prescription, not with recommendations to change lifestyle, which is not going to be easy. We all know that. However, the reality is not so straightforward. Now, signs and symptoms of male infertility, is there any? There isn't any. So that's what makes it very, very difficult. I'm sure we have seen enough situations whereby when a couple come to you, everything is okay, the man was standing, with facing the other direction and saying that it's not my problem. But when the sperm test comes out, there is no sperm. So that kind of scenario, I'm sure, is all very familiar. There isn't any sign and symptoms. Now, you might think that the intercourse might be different, the erection, ejaculation might be different when you have no sperm or low sperm count. No, it's not the case. The quantity and the semen will appear exactly normal to the naked eye, and semen analysis will be necessary to tell whether there is a problem. Next slide. So why could the sperms be poor? Now, these are some of the things that has been suggested that could be the reason why sperms are poor. Now, we are not the same. I've always said that, okay, we have on one extreme, we have the elephant with the ape, the big ape, and then we compare, next slide, to another species. So we are all comparing among mammals to the rats. Now, what is the difference? The difference here is the body size to testis size ratio. All right, so when you look at the apes, the elephant, okay, you can imagine the ratio is going to be quite different compared to the rex, whereby the testis is much bigger. And man is somewhere in between, yeah? So this is what people had suggested in the evolution theory about the K selection, because it is not beneficial for the mating habit, elephant, for the big mammals, to have very good sperm, to be very fertile, to have very high fecundity, because the competition is not good. Whereas the competition is necessary in the rats, in the rodents, in the smaller mammals, whereby the survival is necessary to have the number in order to survive. So that was the first suggestion that telling us that, you know, why the sperms were low in concentration as well as poorer condition in the man, because man is somewhere in between. Next slide. Now, it doesn't make things any better, because if you look at historically from the 1940s till now, this trend is continuing all the way till, this is a very old slide. It stops at 1990, but now we are already 20 years after 2000. It has continued to come down, so the sperm condition has continued to deteriorate. Now, why is that so? I think one of the common suggestions is because of increased industrialization, estrogenizations, processed materials that we are all facing with. So those are all will give rise to all the toxins that could potentially affect the sperm condition. Next slide. Now, this again doesn't make any better, because you know, with increasing, you know, better economy, improvement economy, our lifestyles also become different. So lifestyle factors causing a lot of sperm DNA damage. The damage went on to the embryos, increased risk of miscarriage. Of course, we know that the child born to smoker is 4 times more likely to develop cancer in childhood. So these are some of the things that we've done in the early parts about the impact of smoking. Alcohol has its own share of harmful effect. Next slide. Obesity, when you have more money, you work harder, you become more obese, you eat more. I always tell my patients, sometimes we'll be thinking, your patients will probably tell you, my work is very busy. I got to work from 9 to 9 every day. Now, the more work you do, the more busy you are, the world has already told us that you are not supposed to be very fertile. All right, so one of the reasons is, of course, you know, your stress hormones will be high, your cortisol will be high, you'll resort to stress eating because of the high cortisol hormone. Now, all these will just make things worse. So that's probably one of the reasons why fertility is lower in those better developed places. All right. So obesity in a man is a bad news, because if the androgen is widely converted to estrogen, you know, in the peripheral fat, and this will give rise to total testosterone that is lower. It will affect your sperm production. It will also affect on your virility, sexual function, libido. So all these effects will come in. Next slide. It is not without evidence. If you look at so far what has been seen, just by BMI, body mass index alone, oligospermia, where lower sperm count or sperms that are not moving, it increased across the BMI increase. Next slide. Now, increasingly, I'm seeing more of this now, this masculinity myth. Now, a lot of men, when they come to the fertility issues, when it comes to infertility problems, they're trying to solve the fertility problem, they start going to gym, they start to engage private coach, fitness instructor, to try to get more muscular. But at the same time, you find that there are some of us, find that increasingly, the more you train, the muscle just doesn't appear. So they start to resort to all sorts of supplements, steroid, testosterone enhancing medications. Now, those will be not so good. A lot of them, when they come to us, without any suspicion, they will say, you know, I'm in good form, I take protein shake every day, I work out, I eat clean. So that's quite a word, eating clean. Not so sure what it means. And I have no problem with having sex. So all this misplaced confidence will cause a bit of problem. I think number one, it delays the diagnosis of a male infertility. And number two, you know, it also promotes the use of all these potential sex steroid enhancement products or supplements. Now, we all know that when you use these supplements, especially if they are testosterone containing, they will suppress your sperm production. Next slide. With increasing, you know, better economy, we all have more money, we getting busier, general health also start to suffer. And all this general health, your cardiovascular, your cancer, respiratory, brain, diabetes, or any injuries, all this will have an impact on your sexuality, ability to have sex, your fertility, as well as your virility. So we cannot deny from this. That's why it is important to have a full assessment of the men when they come to you. Once there's any certain issues, you need to look into the background. Now, next slide. Now, I don't think we can get away from this, but I generally would not want to emphasize too much. We know that age does have an impact, but unfortunately, you can't really compare to the age impact on the woman, because the age impact on the man is not so much, but it is there. So if let's say your sperm is no longer that great as you get older, it becomes worse. Next slide. So you can imagine the whole thing, assessment about the male infertility and all that, is basically just looking at the oxidative stress balance. You are looking at all these different factors that will tilt your reactive oxygen's, the stress level against a lower level of antioxidants, giving rise to increasingly more sperm damage, and so therefore affects your fertility. Next slide. Now this is very clinical. I think this is not supposed to be, what should guide our clinical practice, but it has to be in our mind. We would have to look at the male fetal infertility in this way, what is before the testis, at the testis level, and after the testis, what are the possible things that could happen. So the next few slides, I'll just run through what are the things that we do in clinical. I'm sure we are all very familiar. Proper diagnosis, medical history, physical examination and investigation, treatment, and of course, looking at IVF eventually. Now, medical history, there are a few things that are very important. Developmental history, whether there's any previous operation, reproductive history, infection like mumps, trauma, medications. I stress a lot because we are increasingly seeing more and more of this. Later, I'm going to show you a case of my patient. And of course, occupation habits, and of course, in the family, reproductive history. But I find that I put this last because it's no longer very important, because all of us are now getting very small family. So there is not much of family history to talk about. Physical examination is still very important, but I think I can't stress enough. Please, when we see any abnormal sperm, you must palpate the testis, because we will not want to miss a testicular cancer. If you have a testicular cancer, a testicular lump, many a times you get sperm abnormality. All right, so for all our clinicians, I think that's a good practice to do so. The other thing, of course, is the palpation of the vas. Somebody who had no sperm in the ejaculate, the next thing to do is to feel for the vas deferens. If it's not there, if you can't feel it, it's a congenital absent vas. All right, so congenital absent vas is a clinical diagnosis. Next slide. Semen analysis, we're seeing enough of this. There is various modifications, many additions of development, WHO. We'll go into a bit more detail later on. And of course, once the semen analysis is done, we need to look at what are the other blood investigations that we need to do. Typically, we need to look at the hormones to try to find an answer. And of course, sometimes a genetic test might be necessary, especially for cases whereby you don't see any sperm or the sperm is of extremely low amount. Now, I think of the whole talk today, probably this is the most important slide that I would like to stress. I think if you look at male fertility, based on the semen analysis and some of the tests that I suggested earlier, you are able to identify or categorize into 3 groups. So the first group is the most important. I think none of us should miss any of this because this is what we call a potentially treatable group. It is so important because if you treat them, sometime later they come back pregnant. I mean, the wife come back pregnant, of course. All right? So some of the things that are potentially treatable, if you have genital tract obstruction, gonadotropin deficiency, coital difficulties, and of course some of the supplements that we talk about, the testosterone, steroids enhancing medication supplements. So all these are potentially treatable. Unfortunately, you see, you might be thinking, whatever that we're doing here, we're doing all these tests, assessment, and all that. We are only dealing with 12% of the whole group, 12%. But I think we owe our patient that. This 12% is so important because once you start your treatment, they come back successful. All right? Now, I won't go to this group. Unfortunately, this group is also the biggest group. The next group, what we call the untreatable sterility, is mostly all genetic related. Is probably just as much as the potentially treatable group. So this is another group that you want to identify, but in this case, the emphasis will not be so much on how to treat, but rather on how are we going to give the lab the best sample from this patient. So sometimes, you might not be able to get any sample at all, but in that case, at least you try. So I always say that when the sperm count is low, then the potential damage to individual sperms will be very high because sperms is protecting itself by having the number, yeah? What we always say, diluting the toxin. So if you have toxin coming along and my sperm count is very low, the individual damage to the sperm will be huge. Whereas if the sperm count is high, the trouble is divided, is shared. So when the sperm count is low, clinically, you will expect the damage to individual sperm will be higher. So now, the duty lies on us to give to the lab the best sample that we could give. Then only the lab could produce its magic. A bit small, but this is a case many years back, 39-year-old man, 5-year history of infertility, 1 cycle of IVF, EC, diagnosis severe OATS, all the counts, parameters are all low. So at first there were hardly any sperms. They are able to find some sperms and they went through IVF, and there's a typical situation that I mentioned. The IVF success in this case will be low. From very beginning, you know that the fertilization will be low, the embryo development will be low, and chances of getting blastocysts will be very, very low. So it's quite a challenge in this kind of situation. However, with further checking, you found that his FSH and LH were actually quite suppressed. Now, very rarely a suppressed, or what we call a gonadotropin deficiency, you will see a very low level. I would say that probably a level of about 2 to 3 will be considered a suppressed FSH level. So in this case, fair enough, I think what he has is a higher level of prolactin. So this is a pituitary adenoma. Scrotum ultrasound completely normal. And the pituitary MRI confirmed that there is a huge tumor. So these patients, after treatment with your prolactin, medication, toxinets and all that, he responded so well, sperm count started to come out, and she produced and pregnancy happens. So the couple actually did not need IVF. In contrast to another man here, his sperm count is not that bad. There was a certain amount there, but his prolactin level is super high. So they are both tumors arising from the pituitary, but in this case, this is a prolactinoma. Now, prolactinoma will also have its impact on the FSH and LH, and similarly, it will also affect the testosterone. So in this case, so this is the blood test. The testosterone level was 1 when I first saw him. All right, 1. And then after that, with treatment, the prolactin level has continued to drop, and the testosterone level keep going up, and eventually we reached 10.2. He was so happy, and of course, pregnancy happened. So this is an example of how treatment can be very rewarding, and it is very useful to really identify that. Now this is another gentleman that when he came to me, he said that 1 year ago, he went to his family doctor and complained about easy injury. He gets injured very easily because he does a lot of gym work and all that. He looks muscular and big. He does a lot of gym work and he gets a lot of injury, but he noticed that sexual function wasn't very good, poor libido, and true enough, after the blood test, this is what you see. So his testosterone is very good, but somehow, before that. So of course with that, the GP checked his testosterone level, and at the time when it was first checked, it was not this value. When it was first checked, it was marginally lower. I remember it was about 7 to 8 for testosterone level. So he was given testosterone injection. All right, so there is something here. Now, not just one jet. It went on for the next many months, and by the time he came to us, this is the blood test. That is the sperm count, 4.7. And the wife was complaining and that. So when I saw him, it was only about 1 month ago that he has an injection. And that injection is supposed to last for 3 months. And you all know what I'm talking about, right? So the wife said, "Doctor, do something. I'm not going to wait. I want something done. What can we do?" Not so easy. So in this case, actually the best option here is really just to sit tight and wait for it to flush out, to wait for it to blow over. But we've got to try. So indeed, I tried giving him injection with HCG, with GONAF, with FSH, whatever that we could do. Can't improve it much, maybe improve a little bit on the sperm motility and all that. And apart from that, we can't do very much. So in the end, after 3 months, I still had to tell him that we just have to wait for it to recover. So I think we have to be very careful because the response to testosterone treatment in men is a bit different. Sometimes we do not know who will have a bigger impact. Now, there is some clinicians among us that have this belief that some men might benefit from testosterone. I agree, but it is a risk, especially if fertility is on their mind. So be careful with this, because this could potentially be very litigious. So there we are. Those are the potential treatable conditions. What about the untreatable sterility? Now, the genetic cause of oligospermia and azoospermia, as I said, I think the main emphasis here is really to look at how or whether we are able to get any sperm. So that's from the clinician point of view. All right? And also, importantly, we want to say that if we are able to get any sperm, how is this sperm going to be useful for our colleague in the laboratory? Now, chromosome abnormalities is 5.8%, when you have oligospermia, azoospermia 5.8%, and oligospermia 0.38%. sex chromosome abnormality, autosomal abnormality. And one of the things that has a lot of attention placed on is the microdeletion, the Y chromosome microdeletion. 8 to 12% chances of Y deletion in azoospermia, 3 to 7% in oligospermia, and 0.7% in more than 5 million. So it is really up to you. As I said, sometimes the Y chromosome deletion testing is more academic because you can't do anything, you can't treat. Academic meaning that you are able to counsel them about the implication. Okay, so these are all the idiopathic genetic factors, and then you have your Klinefelters, you have Y chromosome deletion, about 10%, and the rest is the absent bars. Y chromosomes so happens in, I think we are mainly concerned about the AGF locus on the Y chromosomes. So the AGF locus have further classified into the AGF-A, AGF-B, and AGF-C. What's the significance? Nowadays, the cytogenetic labs will come back and tell you which AGF is absent, if it is due to Y chromosome. So as I stress, the main importance about knowing Y chromosome microdeletion is really in terms of diagnostic. And when you are attempting to extract sperm, what is the likelihood that you are able to get sperm? All right, so if you have AGF-C, not too bad, all right? Variable, azo or oligo, sometimes you're still able to find sperm in the ejaculate. But AGF-A is severe, and combination of B and C and all that is extremely severe. The usual advice, of course, is that the transmission to the male offspring is obligatory, and the cause and effect relationship is very, very strict and is there. You can't run away from it. Now, this man is very interesting. This is one of the cases that came to see me some time ago. When he came, he was testosterone was only 1.6, so he looks a bit different, hardly any muscle. So after testing, we find that the FSH was sky high, testosterone is low. So the first thing you think about is this is a gonadotropic gonadotropic hypogonadism. All right? Very interesting. So we did the cytogenetic test. The karyotype came back 46SS. Bukan. Not yet. Very interesting. So this is, then after that, you notice another thing, and that is the Y microdeletion testing shows a complete absence of the AGF locus. Complete absence. Very interesting. This is the first time ever I've seen this. I've never seen another one. All right. So this is typically what the textbook describes as XX male, whereby part of the chromosomes on the Y chromosomes has replaced to the X chromosome, and correct, translocation, and the Y chromosome has completely disappeared. So we have to be very careful when you counsel a man like that. Oh, you are actually a woman. No, it's not like that. Now this is another situation. Of course, the karyotype is normal, but you notice that the AGF-B and AGF-C absent. Now, both these examples is exactly what I'm trying to illustrate, to say that in both patients, it is probably not fruitful, not advisable to go on for surgical retrieval of sperm. So it's very important because otherwise it becomes unnecessary procedure. Yeah? So because the chances of getting sperm is 0, there isn't any ongoing spermatogenesis. So back here again, what about this? I'm sure for those of us who are seeing subfertile couple coming for help and all that, this will be the group that you are seeing every day. What are you going to do? IVF. Or, what do people talk about? Supplements. So I think this is a situation whereby you go all out to try to look for what are the factors that have promoted the oxidative stress level. If you can, it's never that straightforward. The treatment of underlying conditions, if you can see any, you try to start off with some supplements, and avoiding any factors that have promoted the oxidative stress. Now, use of antioxidants, I need not stress anymore here. I think all of us, we are aware the evidence is still very lacking. These are just some of the examples that I put on. I don't think the dust has settled on these issues. By all means, please continue on with your anti-supplements. Now, some concern of antioxidant supplements and all that is that everyone, in one way or another, are involved in manufacturing. So we're seeing all sorts of possible contaminants in different supplements and all that. So those are the contaminants or stabilizer sometimes that we're worried about. All right? So of course your patient will say, oh, I only go for reliable sources. Yeah, but how reliable can any sources can be? Huh? So those are the only things that you need to look out for, but I do not discourage really, but I think it's probably not necessary. Conclusion on antioxidant, there isn't any conclusion. Give or not give, what to give, vitamin C, E, or folic acid. Folic acid, I think all of us we know, it has only been given to the woman, mainly concerning some neurotube defect, but lately it has also been given to men. I don't know what for. Yeah. And I think all the trials to date, there has not found any convincing evidence about benefit of antioxidants is really, probably they are not being given long enough, and the dosage could be insufficient. So these are summary. I think sperm function, male infertility can be due to multiple factors. There's an implication on underlying general health condition. Semen analysis is important. No one should get away from the fertility clinic without a semen analysis done. Treatment can be very satisfactory, and I think it's, as I said, we owe them that. If they say there is a treatable condition, you must pick it up and treat it. Antioxidants. Now I'm just going to run through the next few slides quickly, and then mainly about semen analysis. Now semen analysis has gone through many editions. The latest is this. I don't think it matters very much for us clinicians to look at what is the new development in the new editions. It's mainly about, they look at different objectives. I think what matters to me more, and similarly likely to you, will be that now they are coming together to say that there is a lower threshold for all the parameters, below which you can safely say that this is subfertility. Lower threshold, for example, there's a lower threshold for sperm concentration, motility, as well as morphology. This one, I will skip that. Now this is very important. I think we all encounter this sometimes, not common, but if you do have a case, I'm sure you are aware that volume sometimes is important. For in this patient A, volume is normal, pH normal, very few sperms in the pellets. This is probably due to some kind of crypto or maturation arrest. For some reason, the sperms are not able to mature well. So the germ cells are normal, the amount of germ cells are normal, but somehow they are not able to develop into mature sperm. Volume low, again, this is, and I think the typical feature here is pH is low because of prostatic secretion. And I think most importantly, clinically, you palpated and you did not feel the vas, CBAV. The third one is hypogonadism. I don't think that is a big problem. Most of the time, you don't see any sperms, but at the same time, the volume will be low. But the features can be quite diagnostic, and of course, the blood test can tell us too. To make it more complex, there are various, presentations that could be suggestive of what are the underlying conditions. So I'm sure you are also familiar. So I just want to point out extreme actinozoospermia. We have a few cases like that. I think Dr. Liao will be very familiar because these are the cases sometimes it might pose as an extreme challenge to a lab. Because in this case, you are using your conventional method of picking up the sperm for ICSI, you might not be able to do it properly because the sperms are not moving. All right? So you want to find a solution, you ask Dr. Liao later on. Necrospermia. Necrospermia is a situation. So how do you pick up necrospermia? If you look at the semen analysis and you find that the motility is extremely low, you start looking at the vitality or viability. When the viability is low, it's necrospermia. Now, necrospermia, depending very much on the situations, generally, we always say that the chances for this couple to produce a pregnancy is still very high. So it would be good advice to tell them to have more frequent sexual activity, and you will be rewarded. Just tell them that pregnancy can happen. Of course, if they can't wait, then you have to resort to IVF. I'll skip that. Now, just a few words about semen analysis. It's a very valuable diagnostic tool for male infertility. It's an entry-level test and good guidance to tell us what is the next level of test to be. I have this algorithm. When the concentration is there, when it's low, you need to repeat it. You need to check the blood, and if it's confirmed, you refer. Because the chances for any pregnancy naturally to happen here is not realistic. On the other hand, if you have good sperm count, motility is okay, morphology is also okay, then you can afford to wait. If your partner is young, just carry on waiting. But if your morphology is poor, or if the motility is low, these are again absolute factors for poor sperm function. Refer. But we all know, I mean, after the last half an hour or so, we know that the limitations of semen analysis is there. So there's no information about the functional integrity, whether the sperm is all right. We're only able to tell whether the sperm appears good, whether they are moving. There are enough patients out there that we are all seeing that has been subjected to unnecessary treatment because of the sperm test result. And of course, I think one of the major things that we try to avoid now, as much as possible, because our women are all getting older in age by the time when they first came to us, we do not want to delay them. So if there's any issues that you identify that you require IVF, move them on. Now, important rule here, predictive value is poor except when it's azoospermia or severe low count. Just now I mentioned about 0 to 2. And the specific abnormality, you need to look out for all this specific abnormality whereby there is zero motility, structural abnormality, high antibodies. High antibodies is not so much our problem. I don't see very much. But I think in our Caucasian, in our European side, we see a lot of situations like that. There are a lot of advanced semen examinations. I would like to stress only on the DNA fragmentation, so we skip all that. Not so important, but this one, as I think Liao also mentioned something about sperm DNA fragmentation tests. What's the impact? So we'll look at it in a very simplified manner, and that is sperm is a very simple cells. It is basically just a ball of DNA. You fix a motorized tail to it and expect it to function. So therefore, the DNA is just of so much importance. So sperm DNA fragmentation in infertile men, where they will show up with a normal semen analysis. So the conclusion here from this study is that the sperm DNA fragmentation measurement may actually reveal DNA damage in the infertile men. And these studies further affirm that they divide into 3 groups: fertile men, subfertile men, infertile men, and assess them from the semen analysis as well as the sperm DNA damage level. And the conclusion is that the sperm DNA damage assessment is a very independent attribute, regardless of the semen analysis result, of a sperm quality And this justifies the need for both tests in the laboratory for the assessment of male fertility. All right, so Dr. Liao has something to do. What causes SDF? There isn't any clear factors. This is just like what we talk about, the untreatable subfertility. A lot of the conditions that we do not know why. I will to a certain extent, I have to say that it's probably a certain characteristic of a man, but it probably, there are now more and more figures indicating there is a certain degree of underlying problem. Importance, we know, it can cause miscarriage and all that. Okay, we'll skip that. Now the measurement of SDF. Now it's very important because I'm not so sure whether the lab here has started DNA fragmentation testing. We haven't done it. Yeah. So these are the available DNA fragmentation assessment methods. You can see from this table which is the most useful and easiest method to set up. Of course, if you're comparing the different techniques, they are all comparable. So I think that's good information. We've gone through that. Now, what about the sperm DNA fragmentation reproductive result? When the DNA fragmentation is less than 30%, in vivo fertilization, IUI, natural conception, 7 times difference. Yeah? IUI also 7 times. Routine IVF, 2 times more if your DNA fragmentation is low. And of course, EC and routine IVF, 1.6 times more in this study, meta-analysis. Again, similar. I think the other thing that we want to highlight is the increased miscarriage rate when the DNA fragmentation damage is high. So this is also increasingly being recognized. Any effects on the offspring? Now, I think this is one of the questions that's very important to tell our patients. Now, currently, we don't have any figures, but the good thing is that we know that the current studies have already shown that natural conception does not happen. So we need to be careful in IVF. Because you are in IVF, you are picking out the sperm and inject, you are allowing or ensuring that pregnancy to happen. So in a way, you are, might be propagating the sperm DNA damage. What to do? So can't do much. So what are we going to do? We've done all that lifestyle changes, treatment, but basically there isn't any effective treatment to date. So we are resorting to testicular sperm for the last close to 10 years. I think I'm very happy to say that we just celebrated our 10 years Virtus with fantastic result, with all this stress on the male factor, and testicular sperms have produced fantastic results. All right? So, of course, when you talk about testicular sperm, you need to worry about the risk of sperm retrieval. Now, if you are looking at the conventional way of retrieving sperms, whereby you put chunky through-cut needles through the testes, you cause bleeding, you cause loss of sperm function, testicular function, I think that's not right. Okay? So we are resorting to fine needle aspiration, using fine needle and picking out seminiferous tubules, one strain by one strain, of which the laboratory is getting very, very efficient in extracting sperms, good sperms from those tubules. IMSI, so same thing as what a normal ejaculated sperm will be subjected to. The needle extracted sperms will also be subjected to IMSI in order to achieve success rate, a good embryo. Now, why is that so? Now, I think we start to identify sperm DNA fragmentation, the impact on us, especially in our centers. When we first started, we had gone on for routine frozen embryo transfer. At the time, the figures were not so convincing yet, but we decided to go on and adopt it because our result has shown that the frozen embryo transfer were doing so much better. By doing so, we also resorted to routine blastocyst freezing. We do not stop at cleavage stage anymore. So by doing that, we start to identify the impact DNA damage on the chances of blastocyst formation. So the impact is huge. So blastoylation rate is affected when the sperm DNA damage is high. The cleavage stage day 3 to day 5 becomes much affected when the DNA damage is high. Very high failure rate when the DNA damage is high. Poor blastocyst quality when the DNA damage is high. Now, routine IMSI is able to help because IMSI now you look at the sperm at high magnification, you are able to have a better idea of the sperms that you pick up for use is less damage. So our routine now, we do semen, SA together with sperm DNA damage routine for all our cases. Sometimes when the DNA damage is too high meaning, I usually have maybe 30% I could still accept, but anything above 50%, I would say, I'm not going to do IVF as yet. We'll give you some treatment with best intention, whether it's going to help or not, never mind. Frequent ejaculation, and of course, consider frozen samples on standby. When the DNA damage is too high, I delay that for this treatment, and of course, we'll also counsel patient about testicular sperm. All right. Something very interesting, I'm sure you all agree with me. Testicular sperm is very acceptable to the woman. When you suggest testicular sperm for the husband, the woman always says yes. Yeah, we all know why. It's about time. Okay, so this is an early review, testicular sperm versus ejaculated sperm in terms of the DNA damage. Now, just look at this column. The percent spermatozoa with fragmented DNA in the ejaculate is all very high, but in the testes it's much reduced, down to single digit. So it's with good evidence, and I can tell you that with a 10 years data on us, we are quite happy. We are quite happy with the results in terms of live birth rate, in terms of blastocyst formation. Okay, so the results in testicular sperms is compared with 40.7%. This is a percent DNA in testicular sperm. So this is the DNA damage level in the testicular versus ejaculated sperm. And of course, the results, the clinical pregnancy rate is so much of difference. Miscarriage rate, again, so much of difference. And the live birth rate, again, so much of difference. So it's too convincing. So we are now going more and more, and I would foresee, not sure how all our audience will think, maybe this might become the default very soon. Next slide. This is just an example of our patients who had this. So this patient had very poor, no blastocyst formation. So after we've done the testicular sperm, she has 2 beautiful blastocysts. His DNA fragmentation was, sorry, how high is that? I think it's about 50%. This one is also another 50%. Look at the difference in the, from the first cycle, there wasn't any blastocysts, but she produced so many blastocysts after using testicular sperm. This is another one. So this is my last slides. Take-home message, assessment of male fertility, we need to consider sperm DNA fragmentation testing, not just with the conventional semen analysis. Semen analysis is way too old, it's coming to 100 years old. When it first started, it was as simple as just get a sample, look under microscope, stack your lens above it, and then you count the number of moving sperms. So I think those days should be over by now. Knowledge of sperm DNA damage and the impact on reproductive outcome is important. The association is very clear. Treatment strategies for SDF, unfortunately, is very limited. I think for us, the only thing that has been found to be really useful is really the use of testicular sperm. So that's all I have to talk about for male fertility. Thank you very much for your attention.
Okay, thank you Dr. Wan. Have a seat in front. Kita akan masuk ke sesi diskusi. Ya, silakan dari floor boleh tanya langsung. Yang dari Zoom juga boleh ya. Silakan kalau mau tulis di Q&A ini boleh, nanti kita bacakan. Tapi kalau mau tanya langsung juga boleh. Silakan. Prof, ada yang mau tanya, Prof? Kira-kira. Silakan. Dr. Koman. Silakan. kita punya waktu kira-kira 10 menit untuk diskusi. Ya, Prof. Silakan, Prof.
Thank you, Dr. Leo and Dr. Roland. It's a pleasure to meet you again. So, my question is regarding the role of the male factors toward the embryo quality. You mentioned about the sperm DNA fragmentation index that probably they have an impact toward the good quality of embryos. So, in terms of in the laboratory, so do you think that the use of IMSI and also the use of PIXI it will also solving this kind of problem or not? This is my first questions. And then for the Dr. Roland also is very important, and then there's nice data from Harvard Medical School that watching television 40 hours in a week, it will have a bad impact toward sperm quality, including also the sperm DNA fragmentation, and also the use of mobile phone. Yeah, some men they use more than one mobile phone they put in the pocket. Yeah, it will also make a bad impact toward sperm, especially for the sperm DNA fragmentation. So, what is your opinion about this? Thank you.
Let me answer. Thank you very much for the questions. Let me answer the first one regarding selection the sperm DNA, either IMSI or using PIXI, whether it improved embryo quality or not. Now, of course, there's a lot of these publications. They look at meta-analysis, comparing ICSI and IMSI, but to me, meta-analysis, you just look at all those past publications for last 10 years. Development has not caught up with that. Now, they say that IMSI, there's no difference in terms of pregnancy rate. We compare ICSI and IMSI. Yes, there's no difference. But for IMSI, there is a reduction in miscarriage rate and an increase in live birth rate. All right? Not slightly significant of a few percentage. Now, in the laboratory, how are you going to using IMSI to select the sperm? Is it using for the sperm DNA damage? So, Prof. Budi Viveko say IMSI or PIXI. Now, PIXI is another way, but it's not the right way, because there are a lot of publications that say that PIXI improve pregnancy outcome. Now, based on mature sperm, yeah, so-called mature sperm mature, yes, but is there any DNA damage? So there's a lot of studies that shows that PIXI does not, there's no significant difference, either you use PIXI or not, to increase the pregnancy rate or live birth rate using that for ICSI. So to me, the reason why, as I explained earlier in my slide, why we select sperm with better DNA integrity or lower sperm damage is because, as I emphasized, that the egg is a marvelous entity. It has a lot of resources there, and the first thing the egg will do before it becomes an embryo is to do housekeeping work. Maybe what I mean is that using resources to repair the sperm DNA first before becoming an embryo. So if the sperm had high DNA damage, what happens is that the egg will need more of its resources to repair the sperm DNA, and most of the time it cannot correct 100%, and the limited resources later on may impede the egg to reach, or the embryo to reach the blastocyst stage. So by selecting a healthy sperm, but what we have at the latest technology, we're using high magnification based on looking at the vacuoles or holes on the head. We're selecting the sperm with the minimal holes or no holes at all, we can see, is to help the egg to use its resources to for embryo development rather than sperm DNA repair. That will help the outcome. So we have a lot of patients who have had failed cycles elsewhere, at least 2 or 3 cycles, and when they come to the Virtus for treatment, we use IMSI, and we are happy to say that the pregnancy outcome, the clinical pregnancy and the live birth rate have increased tremendously.
So do you think when we use IMSI to select the most beautiful sperm, it is indirectly correlated with lower damage of sperm DNA fragmentations?
Yes. Yeah, because based on what I showed you in this one slide on the electron microscope, where I have 4 sperm there, and you look at the chromatin, looking at the head itself, there will be empty spaces there that's been damaged. Yeah, that if you translate it out, you look at it, it's a vacuum on the head. So that indicates that the sperm had badly damaged DNA. Yeah, I mean the second question is Dr. Roland.
Prof, thank you for the question. That question is very tough to answer, but I will approach it in this way. There are enough headaches and difficulty, mysteries in male fertility. Just like we have seen situations whereby we attribute to maturation disorder, maturation arrest, the sperm count is very low, the germ cells are okay, but somehow the sperm counts are okay. Somehow now we still do not have any answer why maturation arrest happens. The other thing that is also in that area will be the sperm DNA fragmentation. I've seen some of my patients came back with DNA fragmentation level of 90%, 90. So we just don't know why. And so therefore there are just too many unknown in the male infertility area. Now for that to be established facts, I would like to see one day whereby whoever who has done the trial is able to do a prospective trial and eventually, reaching a conclusion and a crossover and reaching another conclusion. I think that's the only way to be convincing to say that, yes, there is an impact. So it is a tough one. I think we know that, sometimes even if a change in the sperm parameter on a certain aspect, it might not affect the chances of pregnancy or produce pregnancy, whether it make a difference or not.
Thank you so much.
Ada lagi pertanyaan? Silakan, Dr. Yuda, Hilma, banyak nih ahli. All of them is the infertility expert in Medan. Come.
Yeah, thank you, moderator, Dr. Hedi. Thank you for the nice presentation. I want to ask Dr. My name is Yuda, from Medan. In Dr. Roland's presentation about the DNA fragmentation index in terms of the high level of DFI, Dr. Roland mentioned about the role of high dose of antioxidant. Do you have a specific antioxidant to suggest to give for the patient, like coenzyme Q10 or vitamin or etc.? And if we give the antioxidant, do we need to recheck the DNA fragmentation index after we give the antioxidant before we do ICSI or IMSI or what we want to do?
Routinely, when the sperm DNA fragmentation index is high, I have starting to offer IVF. But if they are not that high, for example, it's just marginally over 30%, I will still not suggest testicular sperm yet. But if this patient had prior IVF cycles that had not been successful, then I will usually talk about testicular sperm. And for starting IVF in this group of patients, in order to give, hopefully we could give the lab a better time, I always advise them to be on certain supplements, and we use high dose antioxidants, CoQ10, vitamin E. I had quite a bit of emphasis on vitamin E, just for the duration of the stimulation, not to the extent that I'm expecting to see any results, but I'm just hoping that, you know, we can make some difference, because somehow we know that the individual's response to medication intervention can be different. So my answer is still no. If your patient is receptive to having more antioxidants or supplements, go ahead. And if you feel that you don't think it's useful, feel free not to give them.
Thank you.
Ada lagi?
I would like to add, I think it's a very common practice nowadays where, in the olden days also, always before you start the program, you ask the man to abstain 3 to 5 days before the egg collection, all right? Now, ideally, because nowadays we always advise our male patients to ejaculate every day. But of course he can't, because if asked to ejaculate every day, by the time we collect the eggs from the wife, he cannot produce anymore, he's too tired. Yeah? So what we do is that we have a plan. Because if you ejaculate every day, because you know that sperm production is continuous, 24 hours, 7 days a week. And usually when the sperm is produced from the testicle, it goes to the epididymis and stored there. And as you know, the epididymis is very highly vascularized. And there will be free oxygen radicals around. And the longer you store the sperm there, there could be a higher chance of the sperm DNA being damaged there. All right? Whereas those in the testis, there's a barrier. So the risk of damaging the sperm DNA in the testis is less. So when you clear this sperm from the epididymis, then the fresh sperm will go to the epididymis and all the time. So that is the way we are thinking now. So now, what happens is that, instead of asking the man to abstain 3 to 5 days, what you can do is that you can give them a plan that 7 days before egg collection, clear, 3 days closer to egg collection, clear, and then the night before the egg collection, before the man goes to bed, clear one more time. But then the wife and man will say, oh, doctor, next morning may not have enough sperm, but nowadays we're doing ICSI, so they will have some sperm in the next morning, all right? And then we get the fresher sperm with lower DNA damage. That can be found, all right? So this is a way of doing things, maybe in addition to the supplements and all those things.
Ada lagi, Dr. Yuda? Silakan. Samsul, Dr. Samsul. Ada, nggak ada. Ada lagi dari floor? Silakan. Ya, kalau nggak ada, ini ada pertanyaan dari Zoom ya. We have this event, we have offline and online. There's a question from the online. Yeah, is from Dr. Milvan Hadi. The question is, how much is the use of coenzyme Q10 in increasing fertility rate in women during insemination or IVF for women?
From what I've seen so far, I mean, with a short period, many years of treatment, I really don't think that supplements helps very much, not so much in a woman, because I always stress that in a woman is always about the age. The earlier you have it, the earlier you start your treatment, the better it's going to be. If you can't start treatment early enough, freeze your eggs. Unfortunately, I think that is still the most important point. Now, all these supplements, none of this has been useful. Over the years, I've been using CoQ10 as well. But it makes a lot of sense too, because if you look at the eggs, it's not just about antioxidants. It's very much about dissipation of energy over the years. The meiosis process, while you're undergoing stimulation, the meiosis has to be completed properly. The duplicated chromosomes need to be separated nicely into the daughter cells. So all these are energy requiring, and I think there's enough evidence out there to say that the energy level in the eggs is important. Now, comparing the impact on the female, on a woman and a man is very different because the men, the sperms are all fully exposed. I always say that the man's sperm is like a battalion of soldiers going to war, battleground, whereby you have a few layers of firing squads, firing soldiers. The front layers, front squad of soldiers supposed to die first. So that's how the sperms are protecting themselves. Whereas in the egg, it's completely different. It could be just one bottle of water here and the whole building. That's the analogy to the differing in size. So the eggs are well protected. They have a huge amount of cytoplasm with all the active ingredients in there to help to neutralize the toxins. Even if you can't neutralize, you are able to dilute the toxins. So it's not so much as what, all these micronutrients or supplements that could make a difference.
Okay, second question from the same doctor, Dr. Milvan Hadi. When we encounter sperm with the oligoastenospermia, what is the choice of insemination or improve sperm quality? You get the question?
Right. So the degree of oligospermia is probably the most important. As I said, when it is 0 to 2, the chances of a natural conception as well as IUI insemination becomes unlikely, not realistic. But anything above 2, because you will be expecting a certain fluctuations of the level, certain months your insemination volume or amount could still be there. And of course, if you have a very fertile partner, pregnancy could still happen. So I always say that, sperm analysis, seminal analysis is analyzed with a certain background of trying to conceive without success. Without that background, sperm analysis does not mean very much. Of course, if it is 0 to 2, then it is, it is of certain meaning.
Okay, ada lagi yang mau tanya? Okay, that's the time's up. Okay, so kita akhiri dulu sesi ini, nanti kita break dulu, coffee break, and kemudian Prof. Budi akan membawakan tema. Terima kasih. Thank you, Dr. Shu and Dr. Rohan.
Thank you very much.
Thank you, Hedi.
Ya, kembali ke MC ya.
Ya, kita break 10 menit, kemudian kita masuk kembali, kita lanjutkan ke sesi yang kedua. Prof. Viko akan memberikan 2 topik. Coffee break sudah tersedia, silakan para peserta. Coffee break tersedia di luar ruangan. mama awak udah capek-capek sekolah, kalau nggak hasil lagi, aku boleh ke laut aja. Udah capek mama awak misalin awak. Dibebasnya ya. Aku enggak. Cuma tumpah. Oh, sorry. Okay, thank you. Okay, but you can continue. You can sit behind Dr. Rowan. Enggak, dokter nggak pulang, saya tangkap. Nanti selesai, pokoknya saya bawa dokter ini ke sana. Saya dapat apa? Komisi ada? Soalnya saya jadi... Mau pinjaman boleh? Oh, enggak lah, pinjaman, bisa. Pinjaman 0%. Iya, 0% pada saat mengajukan. Nanti bulan depan enggak jadi lah, enggak aku tangkap lah Bapak untuk saya.
Every step feels like a mountain high. Every dream like a distant sky. Nothing's harder, nothing's worse than fearing to take the first. The sun still shines after the rain. Every loss comes with some gain. Open your heart, open your eyes. There's beauty in this wild ride. So dance in the sunlight, sing in the rain. Laugh through the heartbreak, let go of the pain. Life is a moment, don't let it slip. The joy you seek is in your grip. Be brave enough to begin. Let every small joy sink in.
Kepada para peserta, mohon untuk memasuki ruangan karena acara akan segera dimulai.
Count the stars instead of
So good afternoon everyone. We will continue to the next session. And again, this session will be moderated by Dr. Hedi Tan. To Dr. Hedi Tan, the time is yours.
Terima kasih MC. Kita akan mulai sesi kedua ya dengan pembicara Prof. Budi, pembicara satu-satunya dengan 2 judul. Prof, silakan Prof, ambil tempat Prof. Ya, sebelumnya saya bacakan CV Prof. Budi. Nama Prof. Budi, Prof. Dr. Budi Wiweko SPOG, subspesialis fertility endocrine reproductive, MPH, Frankfurt, Hons FICRM, lahir di Jakarta, sekarang pegawai negeri ya, Prof. 4C ya, juga sebagai guru besar di Universitas Indonesia, kemudian riwayat pendidikan S1 ilmu kedokteran di UI, SP1 juga di UI, dan ada Fellow Assisted Reproductive Technology, Haigo College of Medicine Jepang, tahun 2006, kemudian SO2, Immunoendocrine, SP2 ya, SP2, Immunoendocrine Reproductive Universitas Indonesia, S3-nya ilmu kedokteran UI juga tahun 2014. Banyak Prof, dibacakan semua Prof. Ini nggak selesai Prof. Kemudian riwayat pekerjaan, pernah jadi kepala puskesmas ya di mana ini, di Jameka Lubuk Linggau, kemudian Panwaslu Kabupaten Musirawas, Direktur Medik Rumah Sakit Islam Siti Aisyah, staf pengajar FKUI. Cukup dok ya?
Langsung aja.
Iya, terima kasih Prof, silakan waktu dan tempat.
Baik, terima kasih, selamat pagi, Assalamualaikum warahmatullahi wabarakatuh. Saya lebih suka di bawah nih, kayaknya tinggi banget soalnya. Very good morning everyone, Dr. Leo dan Dr. Lelan. It's really pleasure to meet you all. Boleh next slide, boleh? Ya, allow me to speak in bahasa, oke. Ya, jadi terima kasih pada Dr. Mutiara dan teman-teman dari Rumah Sakit Murni Teguh. Pada sesi yang pertama ini kita akan coba melihat bagaimana peluang atau tantangan di negara kita dan developing country ya di Asia Pasifik dalam membangun Fertility Preservation Center atau pusat preservasi fungsi reproduksi. Saya akan mulai dari paper ini. Sebenarnya kita pada tahun 2015 waktu itu mendirikan Asian Society for Fertility Preservation. Kebetulan saya salah satu foundernya bersama teman-teman dari Jepang, Profesor Nao Suzuki, motornya, kemudian Juli, Seido Take. Kita sangat concern betul bagaimana kita harus mengembangkan fertility preservation di Asia, termasuk di Indonesia. Ya, papernya pertama kali publish tahun, pencet. Kok nggak bisa? Ya, oke. Ya, pertama kali publish di ini tahun 2021, tapi kita 2015 ya. Ada expert 14 negara. Waktu itu presiden pertamanya Nao Suzuki, sekjennya Nalini Mahajan, presiden kedua Nalini Mahajan, saya sekjennya. Sekarang presiden yang ketiga Osgur Oktem, sekjennya, wakil sekjennya salah satu Dr. Kemal ya. Ya, yang sangat menarik waktu itu kalau kita lihat bahwa Nao Suzuki is the pioneer. He is the pioneer ovarian tissue vitrification. Kalau di tempat lain slow freezing, maka Profesor Nao Suzuki dan teman-teman di Jepang mengembangkan metode yang namanya vitrifikasi. Sama persis ketika saya research fellow di Hyogo College of Medicine, kita belajar betul bagaimana melakukan oocyte vitrification. Padahal waktu itu 2005-2006 itu slow freezing dengan mesinnya planar itu sangat populer. Jadi ketika saya kembali ke Jepang, vitrifikasi itu masih sangat tidak populer dan kemudian akhirnya sekarang terbukti dia sangat populer ya. Ya. Kemudian kita melihat nih, kita melisting negara-negara mana saja, ini papernya termasuk Dr. Kemal dan Dr. Mila ya yang sangat aktif. Dr. Mila PhD projectnya adalah preantral follicle vitrification, cryopreservation. Jadi kita melisting di negara-negara Asia Pasifik mana saja yang paling established. Kalau kita lihat yang paling established ada Jepang. Jepang dia punya society-nya, Japan Society for Fertility Preservation. Dia ada regulasi, ada guidelines, ada referral system, ada bahkan ada sebagian insurance coverage. Indonesia ya hanya ada sedikit di peraturan PMK nomor 47 tahun 2015 yang menyebutkan tentang simpan beku sel telur, simpan beku jaringan atau ovarian tissue, simpan beku sperma itu ada sedikit. Tetapi yang lain-lain kita belum, kita masih induknya masih Perfitri waktu itu. Indonesian Society for IVF atau Perfitri ya. Kemudian Singapura ya sama ya, dia established ya society. Ya, kemudian berikutnya dilakukan kajian lagi karena di samping adult yang challenging itu juga anak-anak ya, children and adolescent, anak-anak dan remaja. Bagaimana kita membekukan sperma pada anak-anak, pada remaja, nggak mudah. Sebagian besar belum ejakulasi, belum mimpi basah ya, karena itu perlu tindakan-tindakan surgery. Pada anak-anak perempuan, terutama hematologic malignancy, leukemia ya, kemudian limfoma, mereka memerlukan tindakan-tindakan ovarian tissue cryopreservation. Dan ini menjadi concern betul children, adolescent. Sebenarnya kaya, children, adolescent, and young adult. Itu menjadi challenging banget untuk melakukan cryopreservation pada children, adolescents, and young adult. Oleh karena itu kita melakukan studi lagi, kita lihat bagaimana organisasi yang ada di Asia Pasifik dalam memfasilitasi cryopreservation pada children and adolescents. Ya. Lagi-lagi kita lihat memang jarang, yang paling established adalah Australia. Ini lihat ya, Australia dia sangat dia ada organisasinya, kemudian dia melakukan egg freezing, embryo freezing, ovarian tissue cryopreservation, sperm freezing, testicular freezing. Australia melakukan itu semua. Ya. Kemudian Jepang ya, Indonesia ya enggak punya organisasinya ini aja, Indonesian Association for IVF ya. Kemudian kita melakukan egg freezing dan seterusnya, walaupun tidak banyak ya. Yang bekerja cukup aktif itu di Jakarta sama di Yogyakarta, ya UI dan di UGM ya, melakukan cryopreservation pada itu adult ya. Ini kalau children and adolescent. Children and adolescent lebih jarang lagi. Sebagian besar not very often ya, not very often. Indonesia sometimes ya, some of the times. Jepang juga bahkan some of the time. Tapi yang lainnya yes. Filipina juga belakangan mereka punya Philippine Society for Fertility Preservation. Jadi ini challenge ya. Pada anak apa challenge-nya ini dia? Major barrier fertility preservation pada anak dan remaja nomor 1 adalah low recognition fertility preservation among medical staff. Di antara staffnya sendiri tidak terlalu populer. Ya anak-anak, remaja, yakin gak nih kita ya. Kemudian informasi sangat kurang, society-nya. Kemudian ini, pediatric department. Pada tahun 2017 kita melakukan fertility preservation meeting di Jakarta, di IMERI. Diundang pediatrician, mereka bilang, Dok, kita masih struggling dengan survival rate. Boro-boro kita memikirkan fertility preservation, yang penting pasiennya umurnya panjang. Nah ini salah satu kendala ya. Kita lihat nih economic barrier lain lagi. Provide teknologi ya belum banyak. Providing teknologi barrier ya. Kemudian ekonomi karena pembiayaan. Ini weak evidence ya. Jadi ini saya kira challenge di children and adolescents. Dan kita saat ini masih sangat terbatas, kalau lain-lain mungkin ini sangat penting ya, buku, artikel, video dan seterusnya. Di kita baru oral explanation ya untuk menjelaskan bagaimana pentingnya simpan beku atau preservasi fungsi reproduksi pada anak dan remaja. Ya kalau dewasa sekarang apalagi yang lagi populer adalah egg freezing ya, nanti kita lihat ya. Oke, nah ini kita lihat Australia sangat established ya. Medical doctor ini sangat penting, oncologist, oncology, pediatrician, ya, kemudian sampai dengan pediatric surgeon, hematologist, dan ini paramedicals, perawat, psikologis, sangat penting. Di kita masih sangat kurang, tim perawat ya, nursing mungkin nanti di Perfitri ya, Part Meeting Fertility Nursing itu harusnya ada yang membahas bagaimana the role of nurse in fertility preservation. Ya itu masih sangat kurang. Ini Indonesia ya, pediatrik juga kurang, tapi walaupun sekarang onco fertility sudah mulai ya, onco fertility team itu penting. Jadi kalau kita ingin mengembangkan preservasi fungsi reproduksi harus ada onco fertility team. POGI saya akan dorong, ya, kita akan dorong melalui PP POGI untuk lahir onco fertility team atau onco fertility organization. Jadi oncologist semua itu, hematologi onkologi, radioterapi, pediatric oncology, bedah onkologi, bersama dengan reproductive endocrinology harus masuk jadi satu supaya ini bisa berkembang dengan baik. Kalau enggak bakal berjalan dengan baik, enggak akan pernah berjalan dengan baik. Ya kecuali social egg ya, social egg freezing itu aja mungkin. Tapi kalau yang lain-lain itu yang belum ya. Oke. Nah, yang tidak kalah penting juga adalah primary care physician. Ya ini di India. Kita mau lihat bagaimana peran primary care physician, dokter umum. Ya, perannya seperti apa? Ini studi yang cukup baik nih di India ya, Satish Adiga, Teresa Woodruff, ini bosnya di Amerika on fertility. Dia mau lihat bagaimana pengetahuan dibandingkan GP dengan pediatrician. Ini awareness ASCO fertility preservation guidelines ya. Hampir sama ya, tentu pediatrician lebih unggul ya. Knowledge-nya terkait dengan sperm freezing, testicular tissue cryopreservation, egg banking, ini yang paling populer egg banking, ovarian tissue ya, pediatrician sedikit unggul, tetapi opinion bahwa fertility preservation compromise cancer treatment kadang-kadang menganggap kalau kita akan melakukan egg freezing atau melakukan embryo freezing itu bisa menunda terapi kemo ataupun radiasi, sehingga akan compromise cancer treatment. Nah ini salah satu challenging issue juga, termasuk di Indonesia. Makanya onco-fertility is a must. Ya, membangun itu sangat-sangat penting. Ya. Ini frequently initiating fertility preservation discussion with cancer. Ya, GP ya kalah tentunya dibandingkan dengan mostly routinely ini anak ya dibandingkan dengan GP ya. Oke. Apa barriernya? Apa barriersnya? Kalau kita lihat barriers yang terbesar adalah lack of patient awareness. Ya ini menurut pediatrician, lack of patient awareness, financial burden. Nanti ada penghitungannya berapa biaya sebenarnya yang kita butuhkan kalau ingin melakukan egg banking. Berapa biaya yang dibutuhkan untuk melakukan ovarian tissue cryopreservation. Berapa biaya yang dibutuhkan untuk melakukan sperm freezing. Ya. Financial burden, lack of patient awareness, lack of physician awareness, lack of facilities. Ya, cultural, ada juga emotional status of the patient. Ada. Ya, kadang-kadang pasien saya yang penting sembuh. Gitu ya. Saya yang penting. Ya ini kira-kira challenge-nya. Ini di India, gambarnya India. Bagaimana Cina dan Hong Kong? Cina daratan dan Hong Kong ya termasuk yang cukup advance ya. Saya kira walaupun penduduknya tidak banyak ya kemarin ikut Fertility Preservation Society meeting di Hong Kong ya. Kita lihat. Nah, ini dia. Apa single most important factors to consider fertility preservation? Nomor 1 ini, desire to have a children in the future. Nomor 2 umur. Nomor 3 cancer. Nomor 4 funding. Ya, ini di Hong Kong dan di Cina. Jadi dia kalau dia mau punya anak, dia freezing. Sama pasien-pasien sekarang datang kalau di Jakarta, dokter saya mau membekukan sel telur. Kenapa Bu? Saya akan kawin telat. We want to postpone our marriage gitu ya. Dia mau kawin telat, kawin telat. Sengaja, disengajain. Ya kan? Karena dia tahu egg freezing bagus. Nah ini ada ya. Umur juga. Ya sekarang umur 35, 36 datang dia. Saya mau membuka telur saya dok, karena umur saya udah 35, 36. Apalagi AMH-nya rendah, saya akan membukukan ini. Ya, oke. Yang baru nih, type and prognosis of the cancer. Ini di Hong Kong, lihat medical indication, lihat nih. Delay in family ini due of cancer treatment ya. Kalau yang A ini semua medical indication nih. Cancer treatment, ada yang berhubungan dengan pekerjaan, radiasi, kemoterapi, poor quality semen juga nih. Ini juga penting nih. Laki-laki yang spermanya jelek, tadi pagi Dr. Lola menjelaskan. Kadang-kadang with the man with the poor sperm quality, they will declining gradually, bahkan sampai azoospermia. Makanya sekarang sperm freezing ya. Itu penting. Nah baru nih social indication nih, non-medical reason, lihat. Ya kan? Delay, karena career development. Saya mau berkarir dulu. Simpan dulu telurnya. Ya, ini perempuan, ini laki-laki. Dia mau freeze the egg sambil mencari partner. Saya belum ketemu partner, bekuin dulu telurnya. 70%. Ya. Single man juga sama, bukukan sperma. Atau dia pengen punya anak kedua. Nah ini menarik ya. Dari sisi legal regulation, di kita belum ada yang mengatur secara persis. Dari sisi sosial memungkinkan, sisi etik juga memungkinkan asalkan sperma dan sel telurnya digunakan untuk pasangannya yang sah nanti. Bukan untuk sperm donation, bukan untuk egg donation. Nah itu yang ada ya, sekarang banyak melakukan di Jakarta. Dan juga harus inform consent ketika melakukan egg pick up. Maka akan kita sebagian kecil ada merobek himen, ada sebagian kecil karena transvaginal. Tapi biasanya langsung direkonstruksi dengan urogyne bersamaan dengan tindakan egg pick up. Nah ini penting, oke? Di Cina ya lihat, ya Cina akan terus berkembang nih sperm freezing ya, karena mereka luar biasa center IVF-nya yang mengerjakan di atas 5.000 siklus ya, luar biasa. Dan selalu yang namanya fertility preservation pasti nempelnya dengan center of IVF. Ya sekarang salah satu layanan yang sangat seksi dikembangkan dalam center IVF adalah fertility preservation. Bagaimana dengan di Jepang? Nah, Jepang salah satu yang registrinya paling baik. Japan Onco Fertility Registry. Ya presidennya kemarin Nao Suzuki, sekarang diganti sama si Miyuki, ya Miyuki Harada. Ya, dia punya registry tahun 2018. Ya, dibangun registrinya. Kita Indonesia terus terang belum punya. Kita baru punya IVF registry. On-call fertility registry kita belum punya. Ya. Kita lihat bagaimana angkanya. Dilihat ya. Number of patient undergoing fertility preservation. Lihat nih, male naik terus. Sampai 730 ini di 2022 ya. Yang paling banyak sperm freezing. Sperm freezing followed by egg banking, embryo banking, dan ovarian tissue cryopreservation. Ya, jadi sperm freezing paling gampang, It's the most easier ya. Followed by egg banking juga gampang. Dan success rate-nya bagus ya. Egg banking, survival of egg vitrification now is very good. Ya, karena itu orang pede banget melakukan egg banking. Kemudian kita lihat lagi datanya, berapa usianya? Lihat nih, ini male ya. Yang male yang ini yang lebih tua, yang female yang ini. Rata-rata di bawah 40 ya paling banyak. Adalah sedikit di atas 41. Bahkan ada yang 48 jarang. Tapi kalau ASCO, American Society Clinical Oncologist, dia recommended kalau mau melakukan ovarian tissue preservation below than 35 years old. Karena di bawah 35 tahun, aging ovary masih sangat rendah, egg quality masih sangat bagus ya, 35 tahun. Tapi kita lihat nih, ya, ini egg banking paling banyak juga ya. Di usianya paling banyak nih sekitar di bawah 40 ya, egg banking, embryo banking sama ya. Ovarian tissue sama rata-rata di sini Jepang ya. Sperm, kalau sperm memang bisa sampai tua, tapi terbanyak juga di usia 45 ke bawah, 40 tahun ke bawah. Ini gambaran apa yang terjadi di Jepang. Berapa waktu yang diperlukan? Ini juga data Jepang. Berapa waktu yang diperlukan bagi seorang penderita kanker mulai dari diagnosis, kemudian ketemu dengan klinik sampai dilakukan fertility preservation. Lihat ini. Ya, yang A ini time from diagnosis to primary disease treatment ya ini. Dia butuh paling banyak ini 0 sampai 7 hari ya. Kalau laki-laki yang male, yang biru ya, yang biru paling cepat. Rata-rata ya paling dia butuh berapa hari ini? 60 hari, 2 bulan. Ya, 2 bulan. Kalau B ke fertility clinic, yang C sampai ke preservasi. Paling banyak waktunya 2 bulan. Paling banyak rata-rata 2 bulan. Mulai dari diagnosis sakit, konsultasi ke REI clinic sampai dengan fertility preservation. Bisa egg banking, bisa ovarian tissue cryopreservation. Itu pada perempuan, tapi kalau laki-laki 7 hari juga bisa karena sperm freezing dia cepat. Ya sperm freezing, mungkin kalau ini testicular ya. Jadi waktunya ada window sampai 2 bulan. Memang kalau kita lihat algoritmnya, fertility preservation itu apakah ada pertanyaannya, apakah pengobatannya bisa ditunda atau tidak? Kalau pengobatannya bisa ditunda, kita boleh stimulasi. Bisa egg banking, mature egg banking. Ya, kalau tidak bisa ditunda maka bisa immature egg banking atau ovarian tissue cryopreservation. Ada 2 arm. Itu, pertanyaannya itu dulu kalau pada penderita kanker. Nah, bagaimana membangun jaringan fertility preservation? Ini ada benchmarking yang best practice yang bagus ya. Sekarang kita di sini nih tatarannya local and regional network. Ya, kita punya 2 center yang mulai melakukan aktivitas. Ya. Jakarta cukup aktif. Yes, ya, kita punya ini ya 2 ya. Biasanya kalau mau efisien nggak usah bangun banyak-banyak, centralize saja. Jakarta 1, Medan 1, Surabaya 1, Makassar 1, ya, Kalimantan 1. Ya pada negara-negara yang besar ya. Ini sangat penting, sentralisasi, penting sekali. Ini Danish nih Skandinavia, beberapa negara Skandinavia bergabung. Ini Fertiprotect ini punya Jerman, ini sangat established, mostly several facilities, tetap ada sentralisasi. Ya sentralisasi. Kemudian ini penting political activities. Yang paling gede di dunia ada namanya Oncofertility Consortium. Ini terdiri dari 134 fertility preservation center yang bergabung. Oncofertility Consortium dibangun oleh Teresa Woodruff. Tetapi kita saatnya di sini sebenarnya menuju ke sini kalau udah besar ya. Udah besar. Pertama ini nanti mungkin bisa komunikasi kalau Medan membutuhkan fertility preservation bisa terbang center yang terdekat misalkan, atau bisa dikirim jaringannya. Cukup jaringannya berjalan, ovarian tisunya diambil, laparoscopic surgery, ovarian tisunya di slice, korteksnya kemudian dikirim ke Jakarta freezing. Itu bisa model seperti itu, sangat memungkinkan. Atau diterbangkan timnya dari Jakarta awal-awal lakukan di sini freezingnya di Medan. Itu sangat memungkinkan ya model-modelnya seperti ini. Ya, nah ini oke, ya ini yang sangat besar ya, Onco Fertility Consortium. Kalau mau ikut kongresnya biasanya setiap November di Amerika, ya tempatnya Teresa Woodruff ya. Kita pernah mengirim orang juga belajar di sana. Tapi lihat ya, oncologist, REI, gynecologist, nurses, social workers, patient navigator, ini penting sekali. Ada lawyer juga, lawyers, insurance expert, religious leaders, ya penting. Pada tahun 2019 ketika SRM di Philadelphia sebelum COVID, itu mereka melaunching namanya Insurance for Egg Freezing 2019. Jadi ada booth-nya di exhibition itu ada insurance khusus egg freezing. It was 5 years ago. 5 tahun yang lalu ada insurance khusus membekukan sel telur. Ya penting. The lawyer ini penting juga. Karena rata-rata penggunaannya ovarian tissue itu disimpan 10 tahun belum tentu dipakai. Freezing sekarang, the next 10 years, sometimes is still frozen. Belum replace back, belum ditransplantasi. Karena macam-macam faktor. Ya pasiennya belum menikah, belum mau punya anak, masih dalam pengobatan. Ini penting, makanya lawyer juga penting, jangan sampai dijual, jangan sampai dipakai orang dan seterusnya ya. Saya kira itu. Ya ini perkembangannya 10 tahun kalau kita lihat di Onco Fertility Consortium ya, di Amerika ya. Sekarang dia sudah sangat luar biasa membantu pengembangan fertility preservation di berbagai negara. Bagaimana biaya? Ini biaya menarik, ini juga salah studinya teman-teman di Jepang ya. Miyuko Harada nih sekarang nih presidennya. Yasushi Takai sekarang dia di ASFP ya. Mereka menghitung berapa biayanya karena Jepang pemerintah mengcover. Saya ingat Sherman Silver waktu itu dia ngasih lecture di Jakarta. Sherman Silver itu bapaknya ovarian tissue cryopreservation juga. Beliau menyampaikan ada opportunity pembiayaan ERT yaitu fertility preservation. Kenapa? Karena dia cancer. Dianggap fertility karena penyakit. Nah itu di cover oleh insurance. Jadi pasien yang menderita infertility atau POI akibat kemoterapi atau radiasi itu di cover oleh insurance. Ya. Jepang bagaimana? Ini Jepang, lihat. Nah ini dia. Dia di cover, subsidized local central government, catatannya ini tapi. Umurnya harus di bawah 43 tahun ketika melakukan fertility preservation. Kemudian kalau menikah, ya kalau laki-laki istrinya juga harus di bawah 43 tahun. Dan harus didiagnosis oleh dokter bahwa pasien chance kecil sekali untuk hamil ya selain inseminasi IVF atau ICSI. Gitu ya, sangat kecil sekali. Ya, dia hanya bisa hamil dengan IVF. Nah, itu harus ada keterangan itu. Kemudian ini dia harus melakukan fertility preservation di tempat yang certified medical institution. Ya. Nggak boleh juga terima double funding, nggak boleh terima double funding dan harus menikah. The couple must be married atau de facto marriage lah. Kalau jujur enggak. Ini catatan bagaimana Jepang ya. Jepang dia mengcover itu insurance pada kasus-kasus fertility preservation. Dia menarik memang. Ya. Oke. Nah, ini contoh biaya. Contoh biaya. Ini total cost freezing embryo. Total cost freezing embryo mulai dari stimulasi, obat pasti retrieval, ICSI, culture freezing. Kira-kira 500.000 yen. 500.000 yen mungkin sekarang 100 juta rupiah ya. Ya karena ada stimulasi. Yang B ini adalah egg freezing. Ya, unfertilized egg. Ya, sedikit lebih murah, rata-rata 300.000, 60 juta karena dia tidak ada ICSI. Makanya kalau orang melakukan egg banking ya predicted more cost effective dibandingkan embryo freezing. Egg banking more cost effective. Yang C ini ovarian tissue cryopreservation ya, karena ada operasi nih. Dia lebih mahal lagi. Berapa tuh? 600 ribuan, ya 150 jutaan lah. Ya, karena ada operasi, ovarectomy ya 150 juta. Yang D, sperm freezing is much cheaper ya. Sperm freezing 30 ribu, 20 ribu ya, yang 40 juta. Kalau ini TC, it also is much expensive karena operasi ya sampai dengan 100 juta. Ini gambaran biaya. Ya kalau kita ingin melakukan tindakan fertility preservation. Makanya pada saat konseling penting juga itu. Berapa biaya? Kadang-kadang memang pasien mentok di biaya. Dia punya niat, kemudian biaya dia mentok gitu ya. Karena pemerintah kita belum mengcover, kecuali memang sebagian tindakan kayak ini ya. Ovarian tissue freezing, laparoskopinya mungkin bisa ditanggung BPJS, laparoskopinya. Sehingga mungkin little bit cheaper lah ya. Oke, kemudian ini penting transportation network. Ini Jepang juga melakukan itu. Sekarang negara-negara Skandinavia yang bergerak bukan pasiennya. Yang bergerak adalah ovarian tissue-nya. Don't let the patient move. Yang move adalah ovarian tissue-nya. Itu bikin cheaper. Itu bikin efektif. Ya, nanti kita lihat. Ini butuh lihat biayanya. Ini salah satu biaya minimum cost of establishment and maintenance. Sebuah center untuk 30 tahun. 5 juta euro. 5 juta euro itu mungkin sekarang sekitar berapa? 100 miliar. Jadi 1 tahun 3 miliar. 1 tahun 3,5 miliar biayanya. 3,5 miliar kalau rupiah. Ya, 3 billion rupiah. Annually. Ya, 3,5 ya. Kenapa biayanya ini? Ada embryologis, medical equipment, liquid nitrogen tank, ya kan? Nih, dan lain-lain. Jadi costly. Makanya dia bilang tadi kan kalau membangun tuh jangan dibikin beberapa sentral aja, jangan di setiap kota buat karena tidak cost effective. Dia biar kirim aja, jaringannya dikirim. Itu sangat membantu ya. Nah, ini contoh juga bagaimana negara-negara melakukan pembiayaan fertility preservation ya. Yang lain ya, ini contoh ya, yang free banget. Israel semua free sampai 5 kali ya. Slow freezing deh, semua rata-rata slow freezing. Vitrifikasi cuma di Jepang. Vitrification only in Japan ya. Yang lain slow freezing. Jerman covered by insurance ya. Ada biaya transplantasi, biaya transport ada. Tapi Jepang nih lihat ya 5.000 ini untuk removal ovarian tissue, transplantation, transport. Walaupun tadi kalau dia memenuhi syarat dia di cover ya. Coba dihitung berapa biayanya kan 5.000-nya euro loh ini. 5.000 udah 10.000. Ya kan? 10.000 ditambah ini 12.000 euro. 12.000 euro kurang lebih. Ya 120 juta lebih, bisa lebih 200 jutaan ya kalau ovarian tissue, makanya mahal sekali. Makanya ini nih yang mahal ya kan, ini mahal cryopreservation fee-nya. Makanya tadi bikin beberapa center, beberapa titik, kemudian dikirim jaringannya ya. Nah ini transportation network is ideal strategy di Jepang, even di Jepang, to lighten medical fees of cancer, ya the biggest challenge that we are facing now ya. Oke. Secara etik ini nggak ada masalah. The right to reproduce is basic human right, ya patient well-being. Saya kira nggak ada masalah. Bahkan banyak penelitian dia cancer survivor ya punya anak yang sehat ya, bahkan itu meningkatkan sukses rate pengobatan ya. Di Indonesia bagaimana? Ini juga data kita ya. Bagaimana sikap healthcare provider, knowledge and attitude ya regarding fertility preservation. Nih lihat ya tuh. Frekuensi healthcare provider encountering patients ya. Ini masih rata-rata belum always ya, rarely and usually, masih banyak yang never. Jadi ini challenge kita. Ya, challenge-nya masih tinggi. Knowledge-nya aja masih ya belum very knowledgeable ya, masih aware but do not know well ya. Testicular ovarian tissue 6-10, knowledgeable 4-10 ya. Masih banyak harus diimprove. Ya, kalau kita ingin membangun. Dan tapi ini challenge-nya. Kemudian Giving advice, ya giving advice usually ada always consider paling penting ya kan. Ini kemudian discuss impact ke patient, kemudian written information ya masih banyak yang harus diperbaiki ya. Healthcare provider attitude toward fertility observation, agree. High priority to discuss, agree. Ya. Ini juga, tapi ini juga penting. Treated the primary cancer is more important than fertility observation. Ini juga. Ya. Sometimes ini dilema, begitu ya. Comfortable, ya 6-10. Willing to provide less effective cancer treatment, no, disagree. Tetap the best treatment yang diberikan pada pasien. Walaupun nanti pasti akan didiskusikan jenis kemoterapinya apa, dosisnya berapa lama diberikan. Itu sangat mempengaruhi kejadian-kejadian infertility ya. Kemudian factors that health provider consider when deciding to initiate discussion ya. Poor success rate ya masih to some extent. Lack of fertility services in the area ya. Large extent. Ya, di Indonesia tadi saya bilang Jepang, Jakarta, Jogja, Medan udah mulai juga melakukan ovarian tissue ya. Hilma, ovarian tissue cryopreservation udah lakukan belum? Belum ya? Belum. Tapi sooner should be started I think. Ya itu, ya masih lack of area ini ya, service in area, limited knowledge, burden to the patient. Ini kalau pasien ini, apakah akan mendelay ya treatment? Ini penting. Mendelay treatment, poor prognosis ya. Ya itu, saya kira ini yang challenge yang kita hadapi ya. Oke, kemudian 60% frequently discuss fertility to patients ya, ini ya fertility patient discuss ya akan dia pasien inform of risk are more likely revert. Jadi pasien yang memiliki risiko paling tinggi itu yang biasanya diskusi dan deliver ya itu kira-kira ya. Egg freezing ini metode yang paling populer diketahui ya dibandingkan dengan yang lainnya. Cisplatin dan cyclophosphamide juga ini obat-obatan yang diketahui paling banyak yang merusak ovarium. Ya. Gitu ya ini healthcare provider written information masih 32,1%, jarang sekali. Ya. Counseling time. Nih. Ini penting, counseling timing ya, ya. Kemudian extra discussion is timely masih sangat jarang. Ya, ini makanya saya katakan onco-fertility itu sangat-sangat penting. Karena di kita sendiri, healthcare provider sendiri masih belum, ya apalagi di among the patients gitu ya. Nah kemudian bagaimana development di Indonesia, ini development di negara kita. Saya pertama kali belajar di Jepang, Hyogo College of Medicine di guru saya Akiko Hasegawa. Saya melakukan ovarian tissue vitrification dan in vitro culture of follicle in mice pada mencit. Berarti saya paper, guru saya publish paper PubBird sampai lahir tikus ovarian tissue vitrification di fertility sterility tahun 2007. Ya. Ini kemudian kita kembangkan ini ovarian tissue vitrification dan preantral follicle. Dan kita mengembangkan pasien endometriosis nih 2011. Kita melakukan eksisi cortex ovarian tissue cortex ya. Jadi benign gynae. Kemudian 13 pasien breast cancer dan cervical cancer di tahun ini. Ini sudah kita lakukan ya pada saat itu. Ini hasilnya, ini salah satu studi saya di Jepang. We did this is preantral follicle. Preantral follicle after isolation and then in vitro growth of preantral follicle until follicle graft ya, between day 2 until day 8 ya. Ini pada mencit, pada tikus ya kita lakukan itu. Kemudian saya lakukan pada human S3 saya waktu itu. Ini salah satu publikasi kita lakukan ovarian tissue vitrification pada among endometriosis patients. Ini publishnya 2014 sudah cukup lama. Nih, 10 pasien sebagian besar endometriosis kecuali pasien nomor 2 dan pasien nomor 10. Yang lainnya the rest is endometriosis patients. Dan kita lihat ini preantral follicle, pre-vitrification, post-vitrification, number of primordial sampai dengan secondary follicles ya. Ini bersama Dr. Mila waktu itu sebelum dia berangkat ke Edinburgh ya. Ini hasilnya, ini yang pre-vitrification, ini yang after vitrification. ovarian tissue ya. Kita lihat folikel primer, folikel sekunder, sama, tidak ada perbedaan gambarannya. Jadi meyakinkan kita dia bagus. Ini pasien endometriosis yang saya ambil ovarium sehatnya. Jadi pasien endometriosis ada tempatnya ya untuk kita melakukan vitrifikasi ovarian tissue. Ini, ya kemudian kita kembangkan lagi melakukan ini preantral follicle vitrification. Karena pada hematologic malignancy sangat mungkin terjadi micrometastasis setelah dilakukan ovarian tissue transplantation. Makanya kita lakukan preantral follicle vitrification karena ada lamina basalis yang dia proteksi terhadap sel-sel cancer ya. Ini kita lakukan ya pakai kita jatuh ini namanya cryo tissue ya slicing ini dilakukan. Ini kita latihan pada bovine ya kemudian dilakukan pada human ya. Ovarian cortex ya ini primary follicles ya. From fresh ovary ini from follicle from one vitrified ovaries ya. Ini kemudian kita lihat bandingkan molekul pro dan anti apoptosis, Bex, BCL2, Fasligan, Caspase-3 nggak ada perbedaan ya. Ini papernya udah publish nih di Clinical Experimental Medicine ya. Nggak ada perbedaan. Jadi membuktikan bahwa vitrifikasi itu safe. Tidak merusak secara morfologi, tidak merusak secara biomolekuler. Bagaimana dengan morfologi ini? Isolated preantral follicle ini human ya. Human saya pakai librase lagi itu DNase, collagenase ya karena sangat dense. Kalau mencit gampang ya di seksi ini kita susah. Kita pakai librase, ada yang librase plus DNase ya, collagenase. Nah, ini secondary follicle ya. Secondary follicle yang kita bisa isolasi. Kemudian kita vitrifikasi. Kita bisa vitrifikasi ini preantral follicle after vitrification. Bisa. Dan ini bisa ditumbuhkan. Dr. Mila melanjutkan studinya di Edinburgh ya in vitro culture of preantral follicles. Ya. Karena nanti ke depan nih berkembang juga untuk ovarian tissue regeneration, scaffold untuk membuat ovarian tissue dari pasien-pasien yang mengalami premature ovarian failure. Ya, folikelnya ditumbuhkan sehingga dia menjadi ovarium. Kemudian kita juga melakukan studi pada pasien Turner syndrome. Pasien Turner syndrome itu adalah salah satu spektrum pasien yang kemungkinan memiliki peluang untuk dibekukan ovarian tisunya. Dengan catatan dilakukan sebelum pubertas. Karena ketika pubertas, rekrutmen folikel cepat dihabis. Dan kita mencoba ya, kita mencoba mencari dari 20 pasien Turner syndrome nih. Ya, ada yang support group, ada yang enggak ya. Ini knowledge Turner syndrome dia tahu nih fertility impairment Turner syndrome 90% dia tahu. 90% dia tahu ya. Possibility to having children ya. Ini concern of impaired social life, fertility issue mereka concern, attitude. Ya, ini 80%. Willingness to have fertility treatment. Ya, mereka punya harapan yang besar ya pasien-pasien Turner. Makanya kita coba cek ini, kita coba lihat. Semua pasien Turner yang datang kita lihat nih AMH-nya, lihat AMH-nya rendah sih memang 0,08 sampai 0,17. FSH-nya lihat tinggi sekali. Stagingnya stage 1 rata-rata. Ya. Kemudian, nah ini karyotyping ada yang mozaik, ada yang mozaik, ada yang mozaik. Ya. Jadi kalau yang mozaik itu ada peluang sebenarnya untuk di freezing. Karena kalau yang mozaik sedikit lebih tinggi AMH-nya, pasien-pasien Turner ya. Sedikit lebih tinggi dibandingkan pasien yang tidak mozaik. Ya ini lihat pasien Turner, saya sama Dr. Kemal waktu itu tahun 2017 kan kita kumpulin, kita ambil darah, cek AMH-nya ya. Oh ini udah tadi ya, sorry. Ya, itu sehingga ada peluang. Kemudian kita juga melihat bagaimana ovarian reserve pasien cancer ini udah publish juga 2019 ya. Ini kita lihat nih pasiennya 44 pasien di RSM dan dermais ya. Kita lihat ya. Nih pasien cancer AMH-nya lebih rendah dibandingkan non cancer. Pasien cancernya ke gynae cancer atau non gynae cancer, both. Jadi secara alami pasien-pasien cancer memiliki cadangan ovarium yang lebih rendah dibandingkan pasien normal. Makanya hati-hati. Ketika kita akan melakukan fertility preservation pada pasien-pasien cancer, dicek dulu ovarian reserve bagus apa enggak. Nah, ini jelas ya. ada hubungannya dengan BRCA ya, BRCA1-2 column mutation, AMH-nya lebih rendah dia, declining faster. Itu ada hubungannya antara BRCA mutation dan ovarian reserve ya. Ini kalkulator kita ya. Pasien-pasien yang penderita cancer 10 tahun lebih tua dibandingkan biological age ya, dibandingkan pasien normal. Karena tadi dilihat sini AMH-nya 1,1 banding 3,9 ya. Masukin di kalkulator ICO, lihat. Cancer patient 10 years older of biological age compared to the normal patient. Makanya hati-hati kalau kita ingin melakukan fertility observation pada pasien-pasien cancer. Harus diperhatikan betul. Nah ini gynecological cancer dan non-gynecological cancer ini distribusinya. Ini gyne ada 14, non-gyne ada 30. Ya kita lihat bagaimana ovarian reserve-nya. Ya ternyata tidak berbeda. Ya, gyne versus non-gyne sama-sama rendah. Jadi both ya, breast cancer pun dia memiliki ovarian reserve yang lower dibandingkan normal patient. Bukan cuma gynecological cancer. Kemudian pasien endometriosis ini yang paling baru ya. Pasien endometriosis yang kita lakukan ovarian cortex freezing, benign gyne. Karena sekarang kan fertility observation itu bukan cuma untuk cancer, tapi untuk benign gyne, untuk sosial. Ini contoh pasien 21 tahun nih dengan very big ya. Very big endometrioma, Dr. Kemal waktu itu lihat 12 kali 9 kali 3 kali 10, 18 ya. AMH-nya 1,8 sama 2,28 sebenarnya, CA125 tinggi lah. Lihat nih, besar. Kita coba lakukan freezing, walaupun memang hasilnya nggak bagus ya. Kita lihat nih, hasilnya. Tuh lihat, ini pasien normal, ini pasien yang pertama, ini pasien yang kedua. Ya sangat sedikit folikelnya. Ya sangat sedikit folikelnya. Density folikelnya less than normal. Karena nggak mudah mencari looking for normal tissue in the big endometrioma. Makanya endometrioma sebenarnya paling bagus kalau mau melakukan preservasi itu adalah egg freezing. Egg freezing. Tapi ya egg freezing tadi nungguin telurnya juga nggak gampang. Ya ini kita coba, kita paksa lakukan ovarian cortex ya, jumlahnya sedikit. Ya, ini kalkulatornya lihat pasiennya 34 dan 30 tahun, 33 tahun. Kalau diukur AMH-nya harusnya dia 7,2. Ini pasien pertama, ini pasien kedua. Jadi jelas endometriosis patient has older biological age than their chronological age. Ya jelas tuh endometriosis itu merusak sel telur udah pasti ini. Makanya di guideline list 3 yang baru kan, we can offering fertility observation in endometrioma patients. Even dia adolescents ya, even dia unmarried yet. Nah, ini kalau mau lihat ya endometrioma, kapan nih kita lakukan fertility observation? Ini tempatnya. Fertility observation di sini atau di sini? Ya, ovarian endometrioma, yes with high risk. Nah, ini fertility observation atau ini associated with symptom atau ini desire for pregnancy, infertility, yes not immediately fertility observation. Habis itu long term medication atau habis itu surgical treatment. Ini tempatnya. Ada dua tempat spot untuk melakukan fertility observation ya pada pasien-pasien endometriosis. Ya. Terutama pasien yang bilateral endometrioma ya. Ini age-nya di bawah 30, AMI di bawah ini cepat ya harus dilakukan fertility observation. Bilateral endometrioma, recurrent endometrioma after surgery ya. Ini yang harus kita waspadai bahwa ini adalah kandidat ya pasien-pasien endometrioma yang layak untuk dilakukan fertility observation. Ya bilateral, recurrent, ya atau ini ada monolateralnya juga ya. Umurnya di bawah 30, AMH di bawah 10 picomol, ini di bawah 1 ya. Oke. Ini ideal strateginya short term fertility observation strategi. Ya kan, setelah ada benign gyne endometriosis misalkan bisa egg freezing ya. Terus atau ya ini stimulasi egg retrieval ya, kemudian long term terus ya dia ini langsung di ET atau ini nanti setelah sembuh, setelah ini baru kita tanam berikutnya ya. Ini bisa dua strategi. Ya, ini langsung treatment langsung ET atau ini vitrifikasi dulu kemudian nanti baru ditanamnya nanti belakangan ya. Seperti itu. Jadi ada dua strategi. Ya mau mana dulu ya. Oke, kemudian kita juga melakukan studi ini di non-human primate ya di IPB. Kita melakukan studi tentang vitrifikasi sama ya, kita melakukan nih pasien bukan pasien deh, makaka dengan bilateral ovarectomy, ovarian cortex, kemudian ditransplantasi, satu vitrifikasi. Ya ini vitrification, transplantation, transplantasi ditambah mesenchymal stem cell, transplantasi ditambah PRF ya. Ini salah satu yang kita lakukan untuk memperbaiki ovarian tissue transplantation ya. Tapi ini sayang nih belum selesai nih. Mesenchymal stem cell, ini bilateral ovarectomy ya, kita kerjakan di makaka ya. Ini ovarian tisunya. Ini hasil AMH-nya ya di makaka ya. Ini pasca ovarectomy yang sampai 14 minggu baru mulai turun tuh. Kita mau lihat kapan turunnya dia setelah bilateral ovarectomy. Ya ini hasilnya. Ini sekarang yang kita lakukan di Jakarta, kita lakukan fertility observation untuk cancer patients, untuk non-cancer patient, tanda internal juga endometriosis, kemudian ovarian tissue freezing, ya ini guideline dan policy ini yang lagi kita buat ya, bagaimana melakukan itu. Nah ini tempat kita nih Kemal, Dr. Mila ini sama Nao Suzuki di Saint Mariana ya, sudah publish juga papernya. Untuk in vitro, ini preantral follicles ya di mice, persis yang saya lakukan di Hyogo. Kemudian ini di Saint Louis, Mississippi, Profesor Sherman Silber, Dr. Mila dan Dr. Kemal ya, latihan ovarian tissue transplantation ya, microsurgery sama Prof. Silber. Ya, ini beliau. Kita udah siap. Nah ini melakukannya udah cukup lama nih, ovarian tissue transplantation training. Ya, yang ini kita kembangkan sekarang ya, bisa di pasiennya datang ke RSCM, bisa tisunya yang yang jalan ya, transport. Dan ini sudah mulai dilakukan ke the banking. Jadi kita membangun ini supaya bisa berjalan dengan baik di Indonesia karena kebutuhannya cukup tinggi, yang cancer survivor cukup banyak ya. Juga masuk ya social care preservation juga tinggi ya ini. Sudah ada paperwork-nya, SOP-nya sudah ada semua, ya, sehingga bisa dilakukan. Oke, saya kira itu yang paling penting, awareness, ya, kemudian legal economy ini, cost, medical infrastructure penting, makanya harus ada center-center tertentu. Ya. Kemudian guidelines, recognition, ya, technological gap, ya. Ini saya kira dan ini informasi yang sangat penting untuk sosialisasi. Oke, terima kasih. Selamat siang. Assalamualaikum warahmatullahi wabarakatuh. Aduh.
Topik kedua, Prof?
Langsung ya?
Langsung
aja. Nggak pakai diskusi ya?
Sekalian
aus soalnya, aus. Minum dulu boleh ya? Diskusinya langsung nanti ya? Yang kedua mungkin lebih cepat nih. Ya, fertility saya kira sudah banyak ya pasien teman-teman semua menangani kasus-kasus infertility dimanapun berada, apalagi di Murni Teguh ada center IVF ya. Nggak mau ya? Habis baterainya. Oke, kalau subfertility kita tahu ya, hubungan seksual teratur 12 bulan, unprotected intercourse, belum mendapatkan kehamilan. Mengapa demikian? Lihat gambarnya. Karena sesungguhnya fecundity seorang perempuan paling tinggi di 2 bulan pertama. Ya, ini 30%. Setelah 6 bulan harusnya 75% akan hamil. Setelah 12 bulan, mengapa 12 bulan? Karena setelah 12 bulan tinggal 3% fekunditas seorang perempuan. Dan yang belum hamil 35/200, sekitar 15%. Approximately 15% prevalence of fertility, subfertility. Lifestyle ya penting, tadi Dr. Roland udah bilang ya, banyak. Ini loh banyak yang melakukan, mana yang egg damage, mana yang reduce sperm quality, BMI, obesity, ya lean, terlalu kurus, terlalu gemuk itu bermasalah. Exercise berlebihan juga bermasalah. Stress exercise ya, hati-hati gitu ya. Obat-obatan, ya ini increase ya, Pak, ini tadi ya, antioksidan dan seterusnya. Obat-obatan, kemoterapi, radiasi. Jadi jelas ditanyakan dulu, kalau kita punya pasien infertility tanya, ya pekerjaannya apa, occupation ya. Kalau dia berhubungan dengan heat exposure, bakers, ya kemudian tukang las, sopir angkot yang duduk di atas mesin, sangat mungkin ada damage sperm quality-nya, sangat mungkin. Ya, oke. Obesity ini modifiable ya, obesity, smoking, varicocele. Varicocele juga ada very interesting issue ya pada andrology ya, karena increasing heat ya, temperature dan seterusnya ya. Obesity chronic inflammation. Pasien obes itu low grade chronic inflammation dan dia merusak semuanya, oocyte quality, bikin anovulation, bahkan induce endometriosis, PCOS, embryo implantation terganggu semuanya. Ini lihat chronic inflammation. Obesity create female infertility because of nih ROS tinggi ya, homocysteine juga tinggi dan seterusnya. Ya, ini. Working yang tadi saya sampaikan ya, high temperature, X-ray apalagi radiologis. Shifting juga ada, paramedik hati-hati. Ya. Kemudian pramugari, hati-hati juga itu yang kalau dia bekerja melintasi perbedaan waktu. Karena melatonin tinggi kan, kalau gelap melatonin itu kan mengganggu pulsasi general. Makanya bisa tinggi angka fertility. Ya kalau sering pindah yang perbedaan waktu itu sangat mungkin terjadi infertilitas. Nah ada kaitannya dengan telomer nih infertilitas ya, telomer. Pada pasien-pasien yang telomernya panjang ya kan, maka dia lebih baik infertilitas, long telomer dibandingkan short telomer. Kalau short telomere, ya ini fertility associated with short telomere ini. Menopause lebih cepat, recurrent miscarriage, oocyte maturationnya jelek. Pada pasien-pasien endometriosis, telomere lebih pendek, shorter telomere. Ya, ada studinya. Jadi tadi itu endometriosis in accelerating biological age. Kapan mesti datang? Mesti datang berdua. Both couples, husband and wife. Harus dua-duanya. Dan nomor satu yang diperiksa new paradigm, nih, never touch the women without sperm result. Jangan sentuh-sentuh perempuan tanpa hasil sperma ya, are you agree? Never touch the women without sperm result. Cek dulu sperma. Orang 35% karena faktor sperma kok, sperm pathology. 35% sama kayak pelvic tubal, bahkan lebih tinggi dari ovulation disorder. Ya, jadi sperma itu penting banget, male factor apalagi lifestyle. Ya. Ini saya tadi sampaikan ya. Prinsipnya spermatogenesis itu 72 hari. Kalau pemeriksaan sperma nggak normal pertama kali harus diulang. Paling cepat ulangnya dalam waktu 1 bulan. Ya, kalau mau bagus lagi 3 bulan karena spermatogenesis umurnya 72 hari. DNA fragmentation index sekarang menjadi isu yang menarik, tadi kan didiskusikan, first line testing bahkan. DNA fragmentation index, ini studi di kita ya. Studi di kita menunjukkan angka pasien-pasien yang infertil, sperm DFI-nya lebih tinggi secara bermakna. Ya, secara bermakna. Karena kalau sperm DNA fragmentation tinggi, sel telur tidak bisa merepair. Tadi Dr. Leo dan Dr. Lola menyampaikan itu. Tidak bisa di-repair, makanya embrionya kebanyakan tidak pernah sampai blastocyst stage. Fragmented embryo. Dan cutoff point-nya kita di 26,1%. Ya ini, sensitivitas 8. Jadi seorang laki-laki akan mengalami infertilitas ya. Kalau dia di atas 26,1%. Ini gitu. Dia lebih baik dibandingkan konsentrasi, motility, dan morfologi. Ini data kita. Makanya itu didorong sebagai initial investigation untuk laki-laki. Dan ini dari SCM, how to approach the case of azoospermia, tadi udah dijelaskan ada AZF microdeletion. Tetapi saya ingin menyampaikan ini loh, Kalau azo ada faktor produksi, ada faktor distribusi masalahnya. Sebagian besar karena faktor produksi, testicular problem. Sebagian kecil karena distribusi, karena pasien-pasien vasektomi misalkan. Jadi lihat berapa ukurannya, volume testis, berapa hormon ini. Untuk memperkirakan ada atau tidaknya sperma di dalam testis. Kalau volumenya lebih dari 10 cc, 15 cc kemungkinan ada. Tapi kalau volume testisnya di bawah 10 cc hampir pasti tidak ada walaupun dilakukan testicular biopsy. Yaitu paling penting. Jadi pada saat ada pasien azoospermia, kita mesti menginformasikan ada atau tidak sperma di dalam testis. Ya, infertility investigation, ya, saya kira ini sama ya. Yang paling ini perlu diingat endometriosis, ya hati-hati ya. History, comprehensive history harus dilakukan. Physical examination. Ya, kadang-kadang kita malas bertanya, udah berapa lama menikah, umurnya berapa, hubungan seksualnya teratur atau tidak, penetrasi atau enggak. Ya kadang dia menikah 3 tahun, 5 tahun, lakukan periksa dalam, kelingking kita aja nggak bisa masuk ke dalam vagina. Kenapa dia? Vaginismus. Bagaimana mau hamil? Diobati, terapi relaksasi 3 bulan, penetrasi, hamil langsung. Jangan lupa juga suaminya di Singapura, istrinya di Jakarta. Bagaimana mau hamil? Sperma nggak bisa dikirim. Walaupun sekarang ada freeze dry. Sperma dikirim pakai amplop, ya kan? JNE, bisa juga. Gitu ya, ini penting. Tubal patensi, ovarian reserve. Tanya siklus haid, siklus haidnya teratur atau tidak, itu menandakan dia ovulasi atau enggak. Kalau teratur most likely dia ovulasi. Tapi kalau tidak teratur most likely dia tidak ovulasi. Coba ya, jadi yang paling penting basic infertility investigation itu sperm ovulation confirmation, sperm analysis and then tubal investigation. 3 itu the basic yang sangat-sangat basic ya. History taking ya ini ada nggak yang tadi saya katakan menstruasinya, ada nggak riwayat hamil sebelumnya, operasi sebelumnya ada nggak? Kadang-kadang kan ini anak kedua mau hamil anak kedua, anak pertama udah punya kok, biasanya laki nggak mau diperiksa tes, nggak mau diperiksa sperma lagi. Saya udah punya anak, padahal belum tentu. Diperiksa sperma bisa azoospermia bisa, walaupun dia punya anak sebelumnya. Tapi bisa dicek jadi severe oligo atau azoosperma even. Itu menandakan tetap investigasi itu penting walaupun dia secondary infertility ya. Family history ini penting apalagi PCOS, endometriosis ya. Riwayat operasi penting ya, medical history, surgery ini. Pasien yang datang, "Dok, saya sudah operasi endometriosis." Apalagi operasi endometriosis 2 kali, 3 kali, hati-hati. Hati-hati ya. Saat mungkin ovarian reserve jelek. Ini imaging optionnya saya udah jelas ya. Uterine fact, ovulation, USG yang baik kita bisa lihat. Folikelnya besar. Bahkan mau pecah kita tahu, oh ini hampir pecah. Atau rupture, dia corpus luteum kita bisa lihat. Nah itu kita bisa lihat ya. HSG masih golden standard walaupun sekarang ada high COSI. Ya dengan ultrasound, high foci, high COSI kita bisa lihat tubal patensi ya. Hysteroscopy, sekarang chronic endometritis ya, chronic endometritis yang sangat erat kaitannya dengan microbiota and microbiome di cervix and di vagina. Pada pasien-pasien yang mengalami miscarriage itu berbeda populasi lactobacillusnya misalkan. Makanya penting pengobatan probiotik dan sebagainya ya. Oke, ini penting. Tubal factor, uterine factor ya. Ini ya lihat. Confirming ovulation, lihat. Dengan menstrual cycle aja kita bisa mengkonfirmasi ini ovulasi apa enggak. Kalau dia datang, "Dok, saya 6 bulan yang lalu menstruasi terakhir." Oh, udah hampir pasti tidak ovulasi. Bisa karena gangguan WHO kelas 1, bisa WHO kelas 2, WHO kelas 3 atau WHO kelas 4. Ya kan? Kemudian nih ovarian reserve, AMH, antara follicle count. Kadang-kadang kita mesti ngecek progesterone luteal phase kalau ingin mengkonfirmasi ovulasi. Fallopian tube, uterus ya, ini aja. Ini penting saya, clinical work ya. assessment ovulation ovarian reserve ini paling bagus ini. FSH estradiol ya boleh, inhibin B kadang-kadang, tapi AMH antara both is the good standard ya. Ini yang paling bagus dua ini, ya dua ini. Sekarang ini udah hampir nggak dipakai. Ya ini dating dan seterusnya udah enggak. Ini udah hampir nggak pernah dipakai. Ya basal body temperature, dating endometrium udah enggak ya. Jarang, most likely hampir nggak pernah ya. Hormon TSH ini penting pada pasien-pasien anovulasi. Karena TSH itu adalah prolactin releasing factors. Ya, kalau pasien-pasien yang hiperprolaktin TRH-nya tinggi ya. Ini rutin tesnya yang harus dilakukan ovulation, ovarian reserve, ini TSH ya. Transvaginal ultrasound atau saline infusion atau ini. Chlamydial antibody testing perlu nggak? Chlamydia antibody testing. Kadang-kadang orang mencek heat shock protein 60. Tapi orang boleh langsung berikan chlamydial prophylactic dengan azithromycin single dose 1 gram atau doxycycline. Karena chlamydia yang paling penting sebenarnya heat shock protein 60-nya. Ya, dia kan chronic persistent infection, dia akan menandakan kerusakan tuba ya. Oh, mohon maaf nih nggak jelas ya. Tapi itu kira-kira hampir sama. Oke, ini evidence guidelines-nya. Oke, nanti aja kita. Ya, evaluate ovarian reserve. Bagaimana mengukur ovarian reserve? Ini loh. Kalau dia diminish ovarian reserve, kedua ovarium harusnya normal minimal 8 folikel minimal. 8 ke atas dia normal. Tapi kalau 8 ke bawah diminish ovarium, poor responder pada hari kedua atau hari ketiga siklus haid. Ya kalau dia dikurang dari 5 sampai 7 apalagi. AMH-nya kalau di bawah 1 nanogram ya udah pasti. FSH di atas 10. Ini menandakan hati-hati, ini pasien kita sudah mulai kekurangan jumlah sel telur dan harus lebih progresif, harus lebih aktif. Ovarian reserve, nah ini sama ya. Kalau yang sisanya hyperresponder ini pasien PCOS. Ini studi kita nih. AMH di atas 4,5 most likely they have higher risk to suffering from PCOS. Ya ini low responder. Oke, ini ya. Nah kemudian ini ada kalkulator yang kita create ya, kalkulator formula namanya ICO, Indonesian Calculator Outside. Ya ini bisanya di Android ya. Kalau kita bisa masuk ini, kalau punya kalkulator ini bisa tahu kalau diketik 3,5 nanogram umur biologisnya 29 tahun ya. Sebaliknya kalau kita ketik umur 36 tahun harusnya AMH-nya 1,4. Atau ini lihat. Ini membandingkan pasiennya sama-sama umurnya 25 tahun, chronological age-nya 25 years old the same. However, they have different level of AMH, 5.4 and 0.5. So the second patient is they have older biological age, ya, according to the Indonesian Calculator Outside. Jadi pasien kedua ini kita more agresif, udah pasti. Ya, jadi penting, instead of chronological age, biological age what's much more important should be considered. Periksa hormon kapan harus dilakukan? Pemeriksaan hormonal terutama bisa dilakukan kalau nomor 1 siklus haid nggak teratur. Kalau nggak teratur boleh cek AMH prolaktin atau cek ini boleh. Atau decrease ovarian reserve, pasien apalagi dengan bilateral endometrioma. Cek, ya cek hormon boleh. Konfirmasi ovulasi boleh, progesteron ya pada luteal phase, mid luteal phase ya, angkanya 10 nanogram per mililiter. Ya ini bagan kalau kita menghadapi kasus anovulasi, ya mesti harusnya tes P dulu. Ya kalau dia positif, maka nih tugasnya. Kalau tes P positif nih, dia kelainannya WHO kelas 2 apa kelas 4? PCOS atau hiperprolaktin. Kalau dia negatif EP. Kalau EP positif kelas 1 hypo atau kelas 3 ini yang paling berat. Kalau EP negatif kompartmen. Apakah Asherman, apakah TB, endometritis. Approach-nya bisa seperti itu gitu ya kalau kita ingin menangani. Dan ini lihat ya. Kalau tes P positif, AMH-nya tinggi, prolaktin normal, WHO kelas 2. Kalau prolaktinnya AMH-nya normal, prolaktin tinggi, WHO kelas 4. Tes P negatif, EP negatif, EP positif, normal, AMH-nya normal, WHO kelas 1. Kalau EP positif, AMH-nya rendah, kelas 3. Kalau EP negatif, uterine amenorrhea. Ini loh, jadi kalau kita punya pasien dengan anovulasi, harus dibuktikan dia masuk kelompok mana. Karena nanti terapinya berbeda, penanganannya. Ini manajemen yang berbeda. Kalau kelas 1, ini dong, suntik. Ya, kita nggak perlu tahu apakah hipotalamus atau hipofisis. Kalau kelas 1 suntik, FSALH atau HMG, bisa hamil alami, inseminasi, IVF. Kelas 2, lihat pilihannya, lini pertama anti estrogen, lini kedua chronic low dose, lini ketiga IVF. Kelas 3 ini yang paling susah. Kelas 4 hiperprolaktin, obati. Ya, jadi approach-nya, diagnosisnya mesti jelas. Sehingga approach-nya jelas. Sorry. Ya, oke. Kemudian indikasi yang lain nih, kalau idiopatik, ya ini drug of choice-nya. Pasien unexplained fertility, endometriosis, PCOS, malfactor, bisa dosisnya bisa AI, bisa CC, letrozole atau gonadotropin, ya bisa inseminasi. Ini untuk inseminasi. Ya, kalau kita mau inseminasi, target follicle 17 mm. Bisa dilakukan pada unexplained fertility, endometriosis, PCOS atau malfactor. Malfactornya tentunya memenuhi syarat ya. Spermanya di atas 10 juta per cc. Ya, yang potel masih banyak. Ya, kemudian uterine cavity saya kira tadi sudah. Ya, yang the best sih tentu pasti ini ya, hysteroscopy, tetapi office hysteroscopy sekarang saya kira office procedure ya, basic, masuk bagian basic infertility investigation sekarang, office procedure. Kita bisa melihat uterine cavity sangat jelas, bisa melihat ada chronic endometritis. Chronic endometritis itu penyebab infertilitas. Ya, bisa dilihat dengan jelas kalau kita melakukan office hysteroscopy ya. Ini ya. Hidrotubasi is not recommended, nggak ada tempatnya lagi, buang jauh-jauh tuh alat hidrotubasi ya. Zaman saya PPDS dulu, hidrotubasi, sudah dengerin pakai stetoskop lagi. Ya kan? Ini dia hysteroskopi, ini paling penting ya. Laparoskopi sekarang enggak, sekarang orang non-invasive procedure ya, orang melakukan ini, hycosai, ya untuk melihat tuba, hyphosai, hycosai. Bisa kontras, bisa foam, ini sangat gampang dilihat, bisa kelihatan ya bubble-nya. When approach to clinical diagnosis, nah clinical diagnosis itu jelas. Kalau kita melakukan infertility, female infertility investigation, apa diagnosisnya? Apakah tubal occlusion, ovulatory dysfunction, endometriosis, uterine factors, atau male factors? Atau kalau semuanya normal, unexplained infertility. Sehingga kalau udah come to the diagnosis, baru kita bisa treatment. Ya. Kalau nggak bisa treatment, makanya penting sekali. Jadi PCOS salah satunya yang paling banyak ya dilakukan, banyak-banyak ditemukan ya, 5-10% pada kasus-kasus infertility, ya AMH-nya tinggi biasanya sekarang. AMH tinggi. Studi kita menunjukkan pasien-pasien PCOS yang AMH tinggi diberikan insulin sensitizer dalam waktu 6 bulan, dia turun, bisa hamil spontan, tapi panjang. Untuk mempercepat makanya lakukan induksi ovulasi. Bisa dengan gonadotropin, bisa dengan aromatase inhibitor, ya. Oke. Ini saya nggak bicara ini, saya loncat saja. Ya prinsipnya nih ada insulin resistan, ada hubungannya dengan AMH. Makanya pemberian insulin sensitizer itu bisa memperbaiki performance fertility reproductive performance maupun metabolic performance pada pasien-pasien PCOS ya. Weight gain, weight loss ya. Sekarang lagi ngetop adalah semaglutide ya, Ozempic. Ozempic dan itu memberikan hasil yang bagus pada pasien PCOS, obes. Ozempic ya. Itu. Karena sebagian besar pasien PCOS obes ada GLP-1 resistant. Semaglutide obatnya ya, semaglutide. Oke, ini saya skip ya. Aku nggak bicara ini. Endometriosis. Endometriosis is a disease of many theories. Prinsipnya kalau pasien endometriosis adalah obatnya bikin dia hamil, atau bikin dia menopause dulu gitu kan. Shadow pregnancy or shadow menopause. Karena dia resistensi progesteron. Kalau dia hamil dengan progesteron yang tinggi maka dia sembuh. Bisa tertekan endometriosisnya. Nah ini lihat nih prinsipnya. Kalau ada endometrioma lihat ya. Kalau dia ovarian reserve-nya low maka harus ini emergency IVF. Tapi kalau ovarian reserve normal, spermanya normal, fallopian tube-nya pattern, boleh operasi. Bisa inseminasi dengan dihitung endometriosis fertility index-nya. IVF tentu better. Ya. Tapi kalau fallopian tube-nya non patent maka IVF. Spermanya abnormal maka IVF. Ini prinsipnya penanganan endometriosis, endometrioma. Ya. Kalau kita surgery hitung endometriosis fertility index dan prinsipnya adalah the first surgery should be the final surgery. Kalau enggak kita akan recurrent endometrioma. And then treat the patients, not the lesion. Treat the patients, not the lesion. Pasien bisa hamil dengan kista gede, bisa. Pasien saya dengan endometrioma 8 cm, 10 cm hamil bisa dengan IVF. Dan hamilnya bagus. Ya. Dibanding dia operasi, reserve-nya habis, recurrent endometrioma, gak hamil juga. Ya. Temannya endometriosis ada adenomyosis nih, adenomyosis. Kalau adenomyosisnya ya compressed uterine cavity, ya kan? Compressed uterine cavity, uterine is low, maka dia harus operasi, surgery. Biasanya after IVF. IVF dulu, pick up, egg banking, embryo banking. Setelah itu baru operasi. Kalau dia merusak compressed uterine cavity. Tapi kalau dia tidak mengganggu kavum uterine cavity, maka nggak perlu operasi. IVF oke, kalau dia low. Kalau dia normal, sebenarnya bisa hamil IVF tanpa operasi. Ya. Bahkan bisa hamil alami. Jadi sebenarnya adenomyosis itu hubungannya dengan infertility juga still a big questions. Banyak, pas saya terakhir pasien adenomyosis 6 cm, dia hamil twin pregnancy dengan IVF without surgery. Ya, jadi sangat mungkin. Tapi dengan catatan dia tidak mendestruksi uterine cavity. Ya. Oke. Ya ini prinsipnya tuh IVF, endometriosis. Preserve fertility, ya. Keep surgery to a minimum. Ya, treat the patients, not the lesion. Jadi kalau menangani kasus infertility lihat ovulation disorder, tegakkan semua diagnosis. Endometrioma, uterine factor, tubal occlusion atau malfactor. Ya. Nah, harus tegak, ya. Aduh. Sorry, ini udah ya. Ini udah ya, ini tadi sudah ya. Yang paling penting nih, jangan lupa ini apa, konseling ya. Yang lifestyle ini penting nih. Jangan sauna, warm bath ya pasti ya. Dr. Roland ya, excessive physical activity, cycling ya, 40 hours in a week watching television, drama Korean drama. Next, itu penting ya. Ini udah, ya. Bagaimana referral system? Di Indonesia penting ini, referral system kita masih tidak baik. The role of GP sangat-sangat minimal. Banyak pasien come directly to secondary level or tertiary level. Jadi harus push ini primary level supaya referral systemnya baik ya. Gak bisa ya. Nah ini level 1 teman-teman GP harus dilatih supaya dia bisa menegakkan diagnosis. Teman-teman OBGYN ini boleh melakukan tangan infertility, boleh banget. Lihat tapi 36 tahun, di bawah 34 tahun. Ingat ini. Kalau di atas 35 tahun refer ke level 3. Kalau di Medan ada Murni Teguh, ada yang lain-lain, boleh dikirim. Next. Kompetensinya lihat, OBGYN boleh dong, tubal patensi, manage cases of anovulation boleh, endometriosis boleh, uncomplicated tubal blockage boleh. Yang tadi saya sampaikan, silakan tangani dengan baik. Kalau enggak, kirim ke sini langsung lihat nih, yang kompleks-kompleks ini kirim. GP boleh interpret semen analysis konfirmasi operasi boleh GP. Ya, next. Next lagi. Oke, ini contoh, ini pasien endometriosis dengan internal genital adhesion mungkin di level 2 atau 3. Ini pendekatan laparoskopi IVF. Bilateral endometriosis harusnya laporan IVF. Hati-hati coefficient ovarian reserve. Apalagi endometriosis dengan low ovarian reserve langsung level 3. Recurrent endometrioma langsung level 3. Endometriosis dengan sperm abnormality level 3. Adenomyosis level 2 atau 3. Ini harus rujukannya harus benar. Karena kalau enggak kasihan pasien. Dia getting old faster, dia come to the third level, do not have egg anymore. Finish the hope, ya. Next. Ya, endometriosis outside quality oke, terus lagi next. Saya mau skip aja. Bagaimana ovulation disorder? PCOS boleh di level 2, boleh. Tapi kalau udah resistant, failed CC, apalagi pernah chronic low dose gonadotropin langsung level 3. PCOS-nya ini chronic low dose dia failure, ovarian drilling failure level 3. Decrease ovarian reserve level 3 langsung. Ya ini hypothalamic disorder level 2 atau level 3. Harus nih, rujuknya mesti cepat. Cepat dan tepat, ya. Next. Slide please. Sperm disorder, ya Dr. Lolan, ya, most likely I think level 3 ya. Most likely, ya sometimes they have a chance in level 2 for lifestyle modification, insemination, drugs, ya, medications, ya. Next. Lagi. Tubal factor sekarang dengan adanya IVF most likely bilateral occlusion pasti possible IVF. Lebih cost effective dibandingkan tubal reconstruction surgery. Faster, cheaper, ya dan higher success rate, ya. Next. Terus ya ini kira-kira gambarannya bagaimana kita menangani infertilitas, fit and proper test. Ya, number 1, the first step initial evaluations. Ya, ini history taking, menstrual cycle, marital status, job, lifestyle, diet, seterusnya. Chlamydial prophylaxis, ini during second day or third day menstruation. Second visit after menstrual cycle finish, they can schedule for HCG, sperm analysis, hysteroscopy. Third visit langsung, ya discuss result and diagnosis, explain definitive treatment and plan. Jadi 3 kali kunjungan harus sudah fix pasiennya. Apa diagnosis? Atau kalau enggak langsung 1 kali ya mungkin di kunjungan kedua tanpa kunjungan pertama. Dan dijelaskan apa treatmentnya. Next. Sometimes nih yang jadi masalah ya. Nih kalau pasien dari luar kota ya langsung aja hari kedua ya. Atau pasien yang sibuk bisa nih sperm freezing. Sperm freezing ditawarin. Kalau irregular menstrual cycle nggak usah nunggu jadwal haid, datang aja. Ya. Terus lagi yang menyebabkan delay, nih lihat nih, menyebabkan delay nih antisperma antibody yang luar biasa. Dianggap ada antisperma antibody diobatin. Ya, melakukan pengobatan antisperma antibody, PLI, paternal leukocyte immunization. I don't know in Singapore is popular or not, Dr. Lolan, PLI, paternal leukocyte immunization. In our country, sometimes patient receive the treatment of PLI for 1 or even 3 years. Ya, for antisperma antibody. And then it's hydrotubation, diathermy, CC yang enggak rasional, more than 6 months or even more than 1 year. Post surgical DNA agonis enggak direkomendasi lagi post surgical kecuali pain. Kalau mau hamil enggak. Ini toxoplasma aca enggak. It's not recommended anymore ya. Slide. Next slide. Sehingga ini loh level 2, level 3-nya. Level 1 GP boleh ini. Counseling, lifestyle, occupation ya. Semen analysis, interpretation, ovulation confirmation. And then level 2 boleh. ONG boleh, ovulation induction, ovulation stimulation. Level 3 IVF. Rujukannya. Slide. Ini loh ya, algoritmnya ini. Jadi lakukan initial counseling dengan baik, history taking dengan baik, examination, tegakkan diagnosis ya. Kalau di anovulation ini obatnya, ovulasi, inseminasi, endometriosis, sometimes dia langsung IVF, tubal factor langsung IVF, ya sperm bisa IUI, bisa IVF, explain bisa IUI, bisa IVF. Jadi harus dijelaskan pada pasien kita ada di mana, diagnosisnya ada di mana, langkah penanganannya. Slide. Terus lagi, next slide, langsung kayak terakhir. Terus, next slide aja. Ya, take home message. Ya. Nomor 1, timely and accurate diagnosis is primary consideration in the assessment of infertility. Timely and accurate diagnosis. Harus cepat dan tepat. Timely and accurate diagnosis. Dan infertility follow evidence-based protocol and provided according to appropriate level. Jadi harus evidence-based dan ada referralnya tadi. Ada primary, secondary, ada tertiary. Ya itu. Dan terakhir, explanation. A clear explanation, counseling. Apa manajemen plan-nya, apa success rate-nya, starting from the beginning. Jadi pasien paham betul dia harus apa, bagaimana, berapa keberhasilannya, dan waktunya berapa lama. Dan jangan lupa terakhir ibu mesti sabar, sabar dan berdoa. Baik, saya kira itu. Terima kasih, selamat siang, assalamualaikum warahmatullahi wabarakatuh.
Ya, terima kasih Prof. Kita lanjut dengan sesi tanya jawab. Prof mau tetap di bawah atau di atas?
Di bawah aja.
Ya. Oh sebelumnya Prof. Selamat dulu Prof, sudah terpilih menjadi Ketua PPPOGI Prof.
Oh iya, terima kasih.
Oke, ya dari Flor ada yang mau tanya? Mau di bawah aja.
Enggak, di bawah aja sini nggak apa-apa.
Prof mau di bawah.
Lebih enak, kalau ada pengalaman boleh sharing penanganan kasus. Silakan teman-teman, tadi bisa tentang egg freezing, bisa tentang infertility, inseminasi, induksi ovulasi. Silakan. Langsung saja. Dr. Mutiara.
Terima kasih Prof. Aduh, sesi ini bagus sekali. Saya orang awam yang di dalam bidang ini aja sangat tertarik. Saya sebenarnya sangat tertarik dengan preservation. Seperti Prof tahu, memang rumah sakit ini rumah sakit kanker. Jadi banyak sekali pasien-pasien kanker. Tapi saya dengar harganya begitu mahal ya. Bagaimana kita bisa tekan cost-nya sehingga bisa lebih efisien. Dan preservation apakah ada treatment khusus sehingga butuh saya lihat biayanya cukup tinggi. Kalau ini history di luar negeri, bagaimana history di Indonesia? Apakah biayanya begitu tinggi? Terima kasih.
Ya, terima kasih Dr. Mutiara. Pembiayaan cukup tinggi memang tadi ya, kalau itu di Jepang ya. Jepang memang dia lebih mahal lah dari kita. Tetapi kalau di Indonesia, di Jakarta, contoh misalkan kalau kita biasa paling sering 2, egg banking, egg freezing, dan ovarian tissue freezing. Kalau ovarian tissue freezing, laparoskopi. Pada pasien-pasien yang umum, laparoskopinya covered by BPJS. Jadi aman. Tinggal masalah ovarian tissue freezingnya. Ovarian tissue freezingnya itu dia cost-nya itu dari medium, kemudian handling dan freezing. Saya nggak hafal persis berapa, tetapi lumayan lah, it's much cheaper I think than in Japan nih. Kalau nggak salah tuh hitungannya bisa sekitar 10-an ya, 10 sampai between 10 to 20 million ya kalau nggak salah. Itu untuk handling, ovary, slicing sampai dengan masuk ke liquid nitrogen. Tinggal nanti bayarnya per tahun kalau nggak salah berapa juta, 2 juta sampai 5 juta lah per tahun. Itu ovarian tissue cryopreservation. Kita diuntungkan karena laparoskopinya di covered by BPJS. Itu yang pertama. Kalau egg banking permasalahannya adalah kita mesti gonadotropin injection. Jadi seperti IVF, gonadotropin injection mungkin bisa 15-20 juta, pick upnya 10 juta, 15 juta bisa 30 juta. Kemudian egg banking, tanpa lakukan ICSI, ya itu lebih murah, mungkin 30-35 juta bisa masuk. Kalau embryo banking lebih mahal karena dia ada ICSI, di embryo banking. Nah ini yang kira-kira gambaran yang kita lakukan di Jakarta. Walaupun saya nggak tahu ya apakah pemerintah membuka itu ya, allow the opportunity to cover because this is the cancer patients gitu ya. A lot of discussion has been made between us and the government in terms of covering from IVF financial support ya. Masih agak susah sih, karena keterbatasan dana. Nggak tahu kalau insurance ya, kalau insurance karena dia berpikirnya adalah cancer, infertility karena cancer, apakah itu mau di cover? Kita belum sampai di sana, Dok. Kira-kira ini. Nah, delay of the treatment yang bikin masalah kalau di kita adalah diskusi. Karena biasanya pasien di onkologi, hematologi. Makanya awareness dari hematologi onkologi itu penting banget. Kalau pasien-pasien di Jakarta lumayan karena kita sering buat acara oncofertility, Dok. Saya kira nanti kalau mau Murni Teguh buat harus sering bikin pertemuan. Ya, case report, case conference, onkologi dan hari ayah Dr. John Koman merangkap tuh langsung oncofertility ya kan. Jadi awareness dari onkologi itu penting banget. Kalau hematologi onkologinya aware enak banget. Begitu pasien muda langsung deliver ke kita. Kirim ke Yasmin untuk breeding. Nah, di situ ada diskusi biasanya. Dia diskusi lama kan. Ini kalau kita mau egg banking gimana, Dok? Ya berapa biayanya, success rate-nya gimana. Kemudian dia tanya lagi, pick up-nya kan lewat vagina. Ini kadang-kadang bikin tambah lama lagi. Anak saya belum menikah, ini tambah lama. Ini akan merusak hymen dan seterusnya. Ini bikin delay. Itu bikin delay. Ya kan, ngambil keputusan, diskusi sana sini. Yang terakhir biaya tentu, financial. Itu di kita. Ya. Kalau dulu waktu ada masih almarhum Dr. Sigit ya, onkologi beliau sangat aware. Ya, di Departemen Obgyn sendiri sekarang kan pasien-pasien dengan ovarian cancer yang masih muda-muda itu sekarang fertility sparing surgery udah dilakukan dengan baik, dan walaupun ovarian cancer masih belum direkomend untuk freezing ya, tetapi minimal awareness-nya sudah ada ya. Awareness sudah ada ya, kapan nih harus dilakukan freezing, pemberian DNS agonis dan seterusnya, Dok. Gitu sih kira-kira, Dok. Jadi memang awareness itu sangat-sangat penting. Makanya saya mau dorong oncofertility Indonesia karena saya lihat kebutuhannya makin tinggi. Di samping yang kedua, social indication tuh sangat tinggi banget ya. Gitu kira-kira, Dr. Mutiara. Makasih.
Oke. Ada lagi pertanyaan?
Ada lagi pertanyaan?
Ini Prof ada dari Zoom nih.
Oh iya silakan.
Boleh, dari Dr. Milvan Hadi. Selamat siang Prof Iko. Saya mau bertanya tentang egg freezing pada wanita yang belum menikah, anggap hymennya intact, inilah yang belum menikah ya. Prosedur setelah dilakukan induksi kemudian trigger, prosedur ovum pick-up-nya gimana, Dok?
Nah, itu dia.
Dari vagina atau?
Ya, biasanya kita inform consent dulu. Inform consent ketika ibu yakin akan melakukan egg freezing, yes yakin, oke. Kita jelaskan prosedurnya. Ada stimulasi 9 hari, ya, kemudian trigger pick up. Pick up-nya ada 2 cara. Satu transvaginal, which is the most simple procedure dan sangat murah, ya much more cheaper. Atau transabdominal. Memang risikonya kalau transvaginal, hymennya ada risiko robek. Ya, tetapi itu bisa direkonstruksi. Atau kalau nggak mau, ya transabdominal laparoscopic surgery. Of course it's much more invasive and then much more expensive. Itu kita jelaskan dari awal. Nanti kadang-kadang kita urogynecology kita undang juga. Urogynecology kita undang, jelas pada pasien nanti kalau hymennya robek sedikit, ada urogynecology langsung rekonstruksi. Jadi pada saat kita pick up, kalau dia oke, agree, karena memang lebih murah ya. Kalau laparoskopi lebih mahal lagi. Kita murah, kita agree ketika pick up, urogynecology standby. Kita pick up dulu, contoh pick upnya pelan-pelan ya. Kalau bisa pakai probe USG-nya yang kecil. Sekarang USG probe-nya kecil-kecil ya. Pakai USG yang kecil, seminimal, non-invasif mungkin, pick up. Pick up selesai, kalau kita bagus melakukannya dia nggak robek. Karena banyak juga yang elastis hymennya. Tapi kalau memang dia hymennya tidak terlalu hasil, ada robekan sedikit, biasanya langsung rekonstruksi. Karena masih dibius kan, langsung rekonstruksi oleh urogynecology. Biasanya itu, dan ada surat keterangan. Kita berikan surat keterangan bahwa telah dilakukan rekonstruksi pasca tindakan ovum pick up untuk egg freezing. Jadi itu, Dok, itu yang konseling dan secara legal kita mesti berikan itu.
Oke, pertanyaan kedua, Prof. Tentang pasien yang disangkakan ovarium dan akan dilakukan laparotomi, apakah IT-nya dilakukan sebelum laparotomi? Maksudnya, mungkin embryo transfer ya, mungkin ya.
IT-nya.
Nah, mungkin embryo transfernya dilakukan sebelum laparotomi untuk CA-nya atau sesudah? Ini pertanyaan sama.
Oke, begini. Prinsipnya kalau kita melakukan fertility preservation, maka apakah itu egg banking atau embryo banking, maka semua tindakan nanti embryo transfer itu dilakukan sesudah clear pasiennya, free of the disease. Ya, selesai kemoterapi, selesai radiasi, udah clear, boleh hamil, baru tanam. Atau kita transplantasi ovarian tissue back-nya, itu ya, kembali. Biasanya seperti itu. Nah, kalau untuk ovarian cancer ini masih is not recommended. Karena di ovarian cancer ini walaupun dia unilateral, khawatir ada micrometastasis di ovarian tissue-nya. Ini masih belum recommended kalau ASCO guidelines ya. Walaupun debatable juga, orang sekarang mulai mengembangkan. Karena seperti leukemia itu kan ada micrometastasis di ovarian tissue. Tetapi orang sekarang bisa mendetek ya dengan lakukan RT-PCR, dilihat di ovarian tissue ada micrometastasis enggak. Kalau ada micrometastasis dia enggak transplant. Gitu. Gitu Dok, kira-kira seperti itu sih persyaratannya. Gitu.
Ada yang dari floor? Kalau enggak nih Jumadalai 1.
Ya.
Dari Dr. Paul.
Ya, silakan.
Ya, izin Prof, mohon saran. Saya ada 2 pasien kakak beradik usia 26 tahun. Yang satu ini sudah menikah, P0 A0, dan yang satu lagi 22 tahun, Virgo, dengan amenorrhea sekunder selama 3-5 tahun.
Ya.
Oke. Penjajakan yang sudah dilakukan FSH level 95,67, estradiol 13,08, AMH 0,1.
Ya.
Pasien kedua memiliki history of strict dieting, strabismus with, tanpa menopause symptom. FSH-nya 147, estradiol 9,43, AMH-nya 0,23. Kedua kasus memiliki subclinical hypothyroidism, hasil USG, anatomi uterus dan ovarium kesan mengecil. Hasil analisa kromosom keduanya 46XX. Dan ya, pertanyaan saya ada 3 Prof. Apakah penjajakan yang dapat kita lakukan selanjutnya Prof? Pertanyaan pertama.
This is very difficult cases ya, I think. Karena pasiennya premature ovarian failure. FSH-nya 190-an, 145, E2-nya di bawah 30 ya. Kasus yang sangat-sangat severe lah. Yang menariknya adik kakak ya. Adik kakak kan, berarti ada inherited ya. Saya nggak tahu nih, apakah ada gen-gen tertentu, kan bisa premature ovarian failure karena masalah di gen ya. Gennya macam-macam, bisa SF1, SOX9 dan seterusnya ya. Itu satu, kemungkinan genetically inherited, kemungkinan. Sekarang pertanyaannya, dia pernah mengalami amenorrhea enggak? Pernah mengalami menstruasi enggak? Dia primary amenorrhea atau secondary ya?
Di sini katakan secondary Prof.
Secondary ya, artinya dia pernah mens. Kalau dia pernah mens, artinya sebenarnya dia waktu lahir masih ada telurnya itu. Ya kan? Hanya memang rekrutmen itu cepat sekali ketika pasien perempuan umur 15 tahun, itu accelerated primary follicle recruitment. Makanya begitu mens, 1-2 tahun dia bisa habis. Nah ini penanganannya susah, secara umum sulit, ya secara umum. Tetapi kalau mau dicoba, ya kan, itu FSH-nya tinggi sekali kan. Kalau mau diturunkan FSH-nya, kita nggak tahu ya. Kadang-kadang FSH yang tinggi kan seperti gonadotropin resistant ya, sindrom ya. Jadi turunkan FSH. Caranya turunkan FSH paling murah pil KB. Berikan OCP bisa 3 bulan, 6 bulan ya kan. Kalau perlu extended regimen OCP. Jadi placebo-nya dibuang, berikan aja 6 bulan. 6 bulan stop, dia mens kan pasti. Cek lagi FSH-nya, turun nggak dia? Pasti turun harusnya. Ya kan, pasti turun. Nah setelah itu baru dielaborasi yang lain-lain. Apakah ketika FSH-nya turun diberikan anti-estrogen, dicoba ya, dia induksi. Ya kan, kalau mau hamil, tapi kalau nggak mau hamil berikan aja OCP terus. Ya kan, ini kan masih misalkan virgin yang satu lagi saya nggak tahu ya. Itu ya, saya kalau tidak mau hamil berikan OCP terus, dia memperbaiki hipoestrogen, dia menguatkan tulang, yang membuat haidnya teratur. Saya kira is the best treatment is OCP pada kasus ini kalau dia tidak mau hamil. Nah kalau mau hamil setelah FSH-nya turun, bisa elaborasi apakah diberikan antiestrogen, apakah PRP ovarian tissue PRP injection, walaupun PRP ovarian tissue injection pada POI itu most likely nggak bermanfaat ya, no benefit so far gitu ya. Ovariumnya kecil sekali, FSH tinggi sekali, nggak mudah. Kalau mau dicoba itu pun injeksinya lewat vagina udah pasti susah. Harus laparoskopi kalau mau dicoba ya. Tapi sekali lagi itu evidence-nya masih sangat-sangat lemah ya. Masih sangat lemah dan ya mesti lakukan konseling dengan baik. Yang terakhir ya, opsi terakhir kalau di Indonesia nggak bisa ya, egg donation atau adoption itu sampai ke sana sih harus konselingnya. Kira-kira itu. Dok.
Selanjutnya Prof, yang kedua pertanyaannya, apakah kita dapat simpulkan diagnosanya adalah POI?
Yes.
Primary ovarian insufficiency.
Ya, premature ovarian insufficiency, yes, correct, betul.
Okay. And then ketiga, apakah saran tata laksana yang sebaiknya kita dapat lakukan pada kedua pasien tersebut, udah Prof sebutkan tadi. Sementara ini saya sudah berikan tata laksana HRT dan combine
OCP kan? Iya, udah betul.
Ya, betul ya, Pak.
Dan apa OCP dan apa tadi?
HRT, hormone replacement therapy.
Oh, HRT ya, HRT ya dengan OCP. OCP udah is the best lah. Berikan aja itu terus.
Oke,
gitu.
Prof. Baik. Untuk Zoom udah. Ada lagi? Yang lain silakan. Dokter Koman mungkin, Dok.
Dokter Koman.
Masih banyak nih yang dipikir.
Dokter Koman pengalamannya banyak nih.
Saya ada pasien dengan waktu masih anak gadis, dia dengan sel ovarium stadium 1C. Tapi waktu itu dikasih kemoterapi. Tapi sebelum saya kasih kemoterapi, karena satu ovarium dipertahankan.
Ya.
Karena dia mau menjaga supaya dia bisa kemungkinan nanti hamil. Saya berikan GNR analog selama 6 bulan supaya ovariumnya itu tidur.
Ya.
Dan setelah itu kemo jalan. Sekarang sesudah 8 tahun,
hamil.
Ternyata dia menstruasi lancar.
Iya,
nah ini yang Prof.
Ya, betul. Ya, tadi saya belum singgung sedikit, saya belum singgung mengenai genesis agonis, saya baru sedikit sekali tadi. Memang kalau genesis agonis ya di ASCO guidelines dia nggak rekomend sebenarnya. Bila ada pilihan ovarian tissue cryopreservation, genesis agonis is not recommended. Memang sangat debatable sih dok, selalu di event-event fertility preservation tuh debate tentang genesis agonis tuh besar sekali. Karena kan dia hanya menghambat rekrutmen folikel dari preantral ke antral. Itu dihambat di sini. Ya kan? Dia tidak menghambat kerusakan DNA akibat kemoterapi maupun radiasi. DNA damage response is not inhibited by genesis agonis. Makanya kerusakan DNA itu tetap terjadi walaupun di preantral follicles. Yang paling kuat di primary follicle sebenarnya. Yang paling resisten terhadap DNA damage. Gitu. Tapi ya tadi karena considering dia tidak ada manfaatnya, tetap ada risiko kerusakan sel telur. Tetapi pada beberapa kasus case report banyak pasien-pasien adalah dengan genesis agonis itu dia bisa recovery-nya sangat baik, ada menstruasi bahkan bisa hamil ya. Tetapi sekali lagi ini juga ada faktor-faktor lain ya, confoundernya kan jenis kemoterapi, dosis kemoterapi, usia pasien, lamanya kemoterapi, confounder jumlah AMH-nya, ovarian reserve seperti apa jadi sangat banyak. Ya. Tapi so far sih selama ini kalau di ASCO bilangnya gitu, kalau sudah ada ovarian tissue cryopreservation, GnRH nggak direkomendasikan. Tapi kalau nggak ada ya pakai GnRH. Tak ada akar rotan pun jadi ya. Tak ada rotan akar pun jadi. Gitu dok, so far seperti itu sih. Seperti itu. Yang berkembang lebih jauh sekarang adalah namanya ESO1 ya namanya tuh ya kan. Dan AMH rekombinan sebenarnya. AMH rekombinan itu dikembangkan so far untuk menghambat kerusakan folikel dan juga melatonin ya. Melatonin ini studinya PhD student kita di University of Tokyo ya, Dr. Vita barusan menang SRM Prize Award. She received the SRM Prize Award for establishing melatonin ya, for inhibits DNA damage respon akibat kemoterapi. Jadi melatonin ke depan itu juga salah satu ya yang cukup menarik. Gitu dok, terima kasih.
Ada lagi? Dr. Suti mungkin? Dr. San? Ya. Dr. Roland, any question or Dr. Shu? Okay.
How about the experience in fertility preservation in Singapore so far?
I think it's first started, fertility preservation first started in Singapore 30 years. I was involved together with this Professor Yuding, Klaus Yuding, and that was a time when we did quite a few cases of ovarian tissue preservation.
OTC, right.
Back in the year 2006, already started.
Yes.
But then I think we had, I think the major concern here is the cost.
Yeah.
Our cost, and the other thing
Very
is,
high.
I think you also mentioned about political activities.
Yes, yes.
So the take-up rate was very low.
Yeah.
I think the main concern is those few issues.
Yeah.
So we have not taken off very much.
Yeah.
Now lately, our development is mainly into egg preservation. So I have very frequent referrals, but we don't do much of ovarian preservation anymore. We do all egg freezing.
Okay.
Yeah.
We have a good networking with Joyce.
Yes.
Yes. Thank you.
Ya, ada lagi? Ada ya? Oke, baik. Kita sudahi diskusi ini, Prof. Terima kasih banyak, Prof.
Terima kasih, sama-sama.
Ya.
Thank you so much.
Sebagai moderator, saya mengundurkan diri. Terima kasih.
Terima kasih kepada moderator dan juga Prof. Budi yang sudah memberikan materi yang sangat menarik untuk hari ini. Next I would like to invite our speakers and also moderators to stand in front because we are going to give the certificate of appreciation to Dr. Hedi, Dr. Ronald, Dr. Liao, Prof. Iko, mungkin boleh ke depan. Dr. Mutiara, mohon untuk memberikan sertifikat apresiasi kepada para pembicara dan juga moderator. Next session is photo session. I would like to invite Dr. Koman to have a photo session, Dr. Jongkai, Dr. Sharon. Baik, terima kasih. Dengan demikian acara pada hari ini selesai. Untuk para peserta, silakan menikmati makan siang yang sudah disediakan di sebelah. Terima kasih, sampai jumpa kembali di acara berikutnya.
Comes with some game. Open your heart, open your eyes. There's beauty in this wild ride. So dance